Welcome to today is number one of our cardiology lecture series, and we're going to kick it off going strong. Again, the first 40 hours of this refresher is talking about the 2016 National Registry NCCP guidelines. So most of everything we're going to talk about during this first 40 hours is going to be based on the curriculum that they tell us, so we have to go ahead and present. However, we're going to throw in some extra stuff, and then we're going to kind of show what we're doing here. And if you guys across the states or in different states have something different, please feel free to interject. It's very difficult to stretch 2 hours for cardiac arrest management in 2020 AHA updates. So please interject, and the more participation we have, the better off that we'll be. So my name is Larry Manaro. I graduated from Youngstown State University with some associates and with a bachelor's degree. I graduated from the paramedic program in 2008 and have been working as a paramedic ever since through private companies and now fire department. Joe Mistovich recruited me to become adjunct faculty at Youngstown State University, where I've been pretty active even since right after paramedic school as a paramedic preceptor, and then actually having my own class at YSU, and then also teaching bits and parts of respiratory care therapy on EMS aspects of what they might encounter in the hospital if we have to come in with different adjuncts or maybe some crikes. So I was very fortunate and very happy to do that. I've been an educator with Trumbull Regional Medical Center since 2015 when we launched our new progressive protocol under Dr. Howie Mell. He'll be joining us in February to talk more on CCR, cardiocerebral resuscitation. He has since left the area and I believe is in Illinois, but he'll update us when we get there. And I'm a medical student with St. James School of Medicine. I went to the Caribbean. Who knew that college credits had a shelf life of 10 years? I didn't until I realized, oh crap, the time's ticking and I wanted to get in. So I took my first board exam, the USMLE Step 1, I passed. And so I'm going to finish up some clinicals and then take my USMLE Step 2 and then apply for residency. So that's a little bit about me. I've been lingering in the background ever since we started this, but that's who I am. So we're going to move forward with this. And again, please feel free to join and speak up if you need to. So we're going to talk about cardiac arrest. In the United States in 2015, for all out-of-hospital cardiac arrest, there was about 350,000 to 400,000 adults where EMS responded. Less than 40% of those received CPR by a layperson. Less than 12% had an AED applied, and less than 10% achieved return of spontaneous circulation where that actually led to discharge. For in-hospital cardiac arrest, there is about 209,000 adults, and approximately 1/4 or 25% of them achieved ROSC, and they were at discharge. Not very good results, especially in the in-hospital cardiac arrest, only 25%. But in 2020, there was a global study that was done, and it had 141. This was like a meta-analysis, and so of 141 international studies, ROSC was only achieved 29.7% of the time. That's still kind of disappointing considering how much effort, resources, and research has gone into cardiac arrest. The survival to hospital mission was only 22%. That means pre-hospitally, we were able to get ROSC and get into the hospital, into the ER, and then upstairs into the ICU 22% of the time. Survival to hospital discharge was only 8.8%. Pretty grim. EMS out of hospital cardiac arrest to discharge was about 10.5%. And when we talk about EMS discharge, most of that success is reliant on bystander CPR. And of these people, bystander CPR was only done 11.3%. Interesting, from 1979 to 1989, the hospital discharge for survival was only 8.6%. Let's fast forward to the next decade, 2010 to 2019, survival to hospital discharge only went up a few points. It went up 1.3% to 9.9. That's still pretty grim. And that's globally. That's not the United States. Europe and the Western countries in Europe and North America, they actually have high rates of ROSC and better outcomes because of medicine and research being done. We're going to talk about a little bit of the AHA changes from 2015 to 2020. And I'm going to a couple things here. I can get my pen to work. There we go. All right. So let's start with ventilation. When we talk about ventilation, back in 2015, they advocated one breath every 5 to 6 seconds. And so when you thought about that, one breath every 6 seconds is 10, and one breath every 5 seconds is 12. Well, they cut that out, and what they say now is one breath every 6 seconds. So that's going to be 10 times a minute. And again, I'm sorry about my handwriting. The screen is vertical, and I'm trying to write on it and speak at the same time. So we're going to do one breath every 6 seconds. And historically, with everything going on, that's difficult to achieve. We don't always keep that beat of one breath every 6 seconds. We end up hyperventilating our patients. The other thing that I want to caution you on when you do ventilate a patient is the adult BVM has more air in it than what is actually required for resuscitation. And we're going to briefly touch on that. Joe touched on that when we opened up about ventilation, and then Captain Glenn Keating also reiterated that when we talked about airway and capnography. But 10 breaths per minute is what we're aiming for in 2020. For bradycardia, before the guideline said we can give 0.5 milligrams to 1 milligram of atropine every 3 to 5 minutes with a max of 3 milligrams. Now the atropine dose is straight up 1 milligram every 3 to 5 minutes with a max of 3 milligrams. Okay, and that's to prevent arrest if they're bradying down. You can also give dopamine 5 to 20 mics per kilo per minute, and a lot of the areas have switched from calculating the dopamine drip rate and going to an epi-push dose suppressor, which is much easier to draw up and much easier to use. For tachycardia, where you have to synchronize cardiovert anybody, before they recommended for narrow complex tachycardia, such as SVT, that they wanted you to start between 50 and 100 joules. For narrow complex tachycardia with an irregular rhythm, such as AFib with RVR, they wanted you to up that to 120 to 200 joules. And for a wide complex, go ahead and start at 100. But here's the thing. Every device defibrillator out there is different. Zoll is different from the Tempest, which is different from the old school Philips, which is different than Physio Stryker. So now AHA says, whatever the device manufacturer recommends, that's what you want to defibrillate at, or synchronous cardioverts, or deliver the shock at. So, for example, I'm pretty familiar with Stryker, which was Physio, and Stryker Physio is going to go 200, 300, 360. And that's default, and that's for Physio and the Stryker, like I said, and that's going to be automatically unless you change, or your protocol has different specific guidelines of how they want you to shock people. For post-cardiac arrest care, this is where Dan's going to go ahead and talk about, but before they wanted you to try to achieve an oxygen saturation 94% or higher, because we know that 94% was our goal target for everything else, and they realized that maybe that's not good. And the reason for that is, well, your heart and your body just went through a whole, period where you weren't perfusing. So with everything that was going on, you could have some free radicals build up from either the attempt of trying to resuscitate, the oxygenation, or the hyperventilation. So what they did is they said, let's back that down a little bit, and let's do 92 is our minimum that we want to achieve to 98%. So 92. There are some systems out there. Excuse me. There are some systems out there that actually say 90%, but 90 to 92% is where you want to be for the post-cardiac arrest oxygen saturation. For the chain of survival, they had 5 links for both in-hospital cardiac arrest and out-of-hospital cardiac arrest. What they did for 2020 is they added a 6th link, and that 6th link is going to be for recovery and rehab. IV and IO access. So before, in 2015 guidelines, they said that IV and IO access were equivalent, and everybody chose to do an IO access because it was easiest to do. It was the tibial tuberosity, which is 2 fingers below the kneecap, 1 finger medially, and we always, drilled right into the bone of the tibia. And then they came out with the humeral IO, the little bit longer needle, and then we were drilling into the arm because it had faster drug uptake returning to the heart. But in 2020, now IV is preferred over IO access. Now let me kind of say something here. If you don't have a clear shot of it at a vein, don't waste time trying to get that IV. If you cannot get that IV, go right to IO. But if there's a vein that pops out, do that, because what they're saying is the venous route is going to go straight into the heart to have more of an effect versus the intraosseous space where the capillaries are there, because they think that there might be less absorption of that drug through the IO access. So IV is preferred, but if you can't get the IV, then go for the IO. For cardiac arrest, specifically in 2020, they're still advocating for 1 milligram of epi every 3 to 5 minutes, or instead of trying to calculate that, what they did is they said, you know what, let's just go every 4 minutes as a mid-range, right? So what that does is that takes it to every other 2-minute rhythm check. And because of this, a lot of people and a lot of protocol and medical directors have said, let's go ahead and let's put our monitor defibrillators in AED mode, and then that should bring us right to our 2-minute cycle where we need to either swap out compressors or when we need to analyze that rhythm and see what's going on. So every other rhythm check, they said is okay for epinephrine. Moving forward, lidocaine is now back to being equivalent to amiodarone. Either may be used. However, if you have a pregnant female, then I'm going to say lidocaine is better. The reason is amiodarone is going to be an iodine derivative, and that is actually teratogenic, which means it's going to have abnormalities for the growing fetus, and it could actually have disruptions in thyroid and growth development. So if you have a pregnant female and you have both lidocaine and amiodarone, we prefer lidocaine for pregnant females and amiodarone for just about anybody else. But they're equal. That's the main thing to keep in mind. They also talked about an algorithm for ventricular assist devices, and this is going to be after the new year, January 4th, I believe, and that's going to be done and talked about by the Cleveland Clinic Critical Care Transport Team. They have joined us in wanting to go ahead and talk about this. They put a lot of them in Cleveland, both University Hospitals and Cleveland Clinic. I've been doing some research and talking to some people, and the Cleveland Clinic will take their ambulance and they will actually drop off batteries to people if they're out shopping, if their LVAD decides to get low on juice. So that's going to be coming up in January. Also, they added some new stuff about deciding how the neuro outcome of that patient is. And so that's going to be beyond us. That's more so for the in-hospital, but they're going to do CT, MRIs, stimulation, and they're going to figure out what brain activity is going on. And then they're recommending waveform capnography with a bag valve mask device. On our second installment, we talked about the importance of capnography and that capnography can really guide your treatment. So for CPR, for capnography, we want the end tidal CO2 to be between 10 and 20, ideally 20. And that means that you're doing good chest compressions, right? If your end tidal CO2 does not get to that 10 to 20, then you need to readjust and figure out what's going on with the compressions. Is that person who's doing compressions tiring out? And let me emphasize that doing CPR for 5 minutes does not make you a great EMS personnel. The science shows, and I think we can all agree, doing CPR for 2 minutes is very tiresome. And wouldn't you rather have somebody come in at that 2-minute mark and take over? Because I know I would. So if the rescuer is getting tired and you know, hey, I got to switch this up. Hey, Matt, get in here and do these compressions. I need a break. That might be one of the reasons why your end tidal CO2 is low. So keep that in mind. So end tidal CO2 in cardiac arrest resuscitation is an indicator of compressions. I told you that they talked about the chain of survival and they added a link, and I'm going to go through the first one of these here. So activation of emergency response is first, then they advocate for high quality CPR, defibrillation, advanced resuscitation, which is where EMS comes into play at, post cardiac arrest care, and recovery, rehab, maybe some social work. Going through cardiac arrest and literally being dead can be pretty traumatic. So they're going to have some counseling with that. And maybe those patients have some PTSD that they need help with. Also, occupational and physical therapy, rehab, to try to get them living their life the way that they were before. So that first link is the activation emergency response. And this is a shot of an iPhone here. And it's pretty cool because when you start to dial 911 of an iPhone, it automatically comes up if that patient has some sort of medical information. It'll come up on the bottom corner, medical ID. And I recently used this on a trauma. A guy fell 20 feet from a ceiling, and he had a phone, and all it said was his name. But I clicked on his medical information button that you see right down here, and I was able to find out what his name was. That's all he had in there. But if you actually use that to the full extent, you can put name, emergency contact, meds, history, and so on. But 911 is what the emergency response is. So you can call 911 from any phone, a landline and a cell phone, whether it's a telephone company or cable company, they all have your address on file. You can also call 911 from the cell phone or a cell phone that's deactivated but has battery life in it. You call 911, they'll be able to connect you to the operator. There's new planning for a new generation 911 where you would be able to actually text 911. So if you're in a situation where you might not be able to speak, or for those who might be deaf, who doesn't have the ability for that teleprompter, that transcription of the words that they're trying to say, that's in development, and they're testing that out right now. We've all been on that medical alert pendant. We get there and either somebody bumped it by accident and it was a false alarm, or they push it and they're actually in dire need. So those also are GPS encoded. So I know that some of them that are hardwired to the base, they automatically respond that person to that person's house. But some of them, the pendants that you have a little bit more advanced, they have a little SIM card in there. And then if you push that, then they'll know exactly where you're at any time. So medical alert devices are big. And then public defibrillators. And we're going to talk about public defibrillators here in a second and why they're so important. So the second chain of survival was high quality CPR. So in the 1950s, different scientists were trying to figure out how do we try to save people whose heart has stopped. And so CPR was essentially invented in the 1950s. In the 1990s, public defibrillators were big, and they started to try to figure out where can we put these, because they knew that early access and early defibrillation was something that could restart the heart and have return of spontaneous circulation. When 2010 came around, they realized that a lot of people weren't doing CPR because they didn't want to do mouth to mouth. And that's when your hands-only CPR came around. In 2020, they're emphasizing early CPR and early defibrillation. For CPR, nothing's really changed for 2020. Push hard, push fast. The rate remains 100 to 120 per minute. The depth is 2 to 2.4 inches, but don't exceed that 2.4 inches. And the ratio is 30 to 2 with a BVM. I want to say that if you're using a BVM, then they are advocating for a 2-rescuer BVM, which means that one person would hold 2 hands on the face mask, pressing it down and bringing that, well, let me rephrase that, bringing the mandible up to the face mask, and one person would actually squeeze the bag about half of a squeeze. And here's the key thing: swap out at 2 minutes or 200 compressions or any sign of fatigue. So defibrillation, this is a clever idea. They put an emergency defibrillator in an AED sign right underneath the emergency lighting. That's pretty cool. So I know that when you go to some of the larger city malls or some of the large airports, those AEDs, public defibrillators, are all over the place. In fact, when Dr. Mills talks about his cardiocerebral resuscitation, he's going to tell you if you have a cardiac arrest in Chicago, you're more likely to have a chance of survival if you have a cardiac arrest in the Chicago airport versus in the city. So that has big public awareness, and the AED is actually pretty good at having return of spontaneous circulation. For sudden cardiac arrest that's truly cardiac in nature, that accounts for about 70% of all cardiac arrest. And most likely, if it's cardiac in nature and they go into sudden cardiac arrest, it's most likely to be ventricular fibrillation, VFib. And so essentially what that is your heart is like this versus your normal QRS. And between as soon as it happens to up to 5 minutes, that's called the electrical phase of the heart. And when you're in the electrical phase of the heart, you actually have the best chance of survival by getting early defibrillation, to have ROSC, to have almost zero neurological deficits, and your highest chance of survival to discharge and ongoing the life that you had before you went into cardiac arrest. So early bystander CPR with an AED is actually your best chance of survival. You heard me mention the electrical phase of excuse me, electrical phase of the cardiac arrest. And this is just kind of what I want to show you. This 0 mark here references the time that the patient actually goes into cardiac arrest. So what happens here on top here, you're going to see the myocardial ATP, the energy that the heart has. When we stop that heart, or when that heart does not perfuse correctly, 100 represents the best or all the energy that the heart has up here, and then this 0 represents no energy whatsoever. So that electrical phase that I talked about, that is going to be from this time of onset of cardiac arrest to right about the 5-minute mark. And that's when we need the defibrillation in there. And so that's why when we talk about VFib arrest algorithm that we're going to see later on, if the patient goes down in front of you and goes into VFib less than 2 minutes, when you see them, go ahead and defibrillate first, because that's going to convert them out of that VFib and get them to a state where they still have about 30% of their ATP left in the heart to try to restart it. When we talk about the circulatory phase, that's going to do from about 5 minutes all the way to about 10 minutes here. And so when that happens, you can see by this green graph here that I've used all of my ATP. Pen's not working, so all of the ATP. And so by doing so, the defibrillation is not very good, because if I have ATP, the cells are still excited. They're still moving. The sodium potassium pump's still working. You have excitability, automaticity. So you're going to be able to convert that. But if the average response time in the United States for an ambulance is 9 minutes, where does that put us? That puts us here, which means the ATP of the heart is diminished. If you're in a system that has tiered response, that has police, fire, and that transporting ambulance company, that's where you get early access to defibrillation. That's where you get CPR, and that's essentially where we're trying to start, is right here at the 4-minute mark. So minutes 5 through 10 is the circulatory phase. We know that the ATP is used up, and the key thing is the left ventricle is empty from blood. So we need to start trying to get that restarted and try to get maybe some fluids in there to circulate out into the body. Most likely, if we defibrillate these patients in the circulatory phase, we're going to put them in asystole or PEA. PEA, why? Because we're out of blood. There's nothing in there to cause a contraction or cause a blood pressure. So when we're in the circulatory phase, or by time that average ambulance shows up in the United States, what do we do if the patient's in VFib? We want to do compressions first. And we want to do compressions to prime the pump for about 2 minutes. And that's what the ACLS algorithm says, and we'll get into that later on in the lecture. Beyond the 10 minutes, we actually get into the metabolic phase, and that's where you actually shift to acidosis. That's where the myocardium dies, and that's when you're going to have 10 minutes and beyond, and there's not much that we can do pre-hospitally. So try to get there before 10 minutes, and that's going to be your best chance of survival. So just a little bit of physiology of resuscitation. Compressions, right? When we compress in the thorax, it causes differences in intrathoracic pressures. So compressions will actually increase the intrathoracic pressure, causing the blood to push out. And then the chest recoil, when you lift completely up off of that chest, will result in a decrease in the intrathoracic pressure, allowing blood to return to the heart. When we talk about oxygen and ventilation, studies have shown that satisfactory levels of oxygen for up to 9.5 minutes following VFib are pretty good. It equates to an SpO2 of about 93% or a PaO2 of 77%, 77 millimeters of mercury, right? And if you're wondering, 90%, which is where we talk about for chest pain algorithms, you know, don't give oxygen until it's 90%. 90% equates a PaO2 of 60 millimeters mercury. So 90%, because anything below 60 millimeters mercury, 90%, we know that patient is very hypoxic. So during resuscitation, we actually get a little excited and we positive pressure ventilate with a VVN. But if you're doing one person doing the CE clamp and you have your other hand squeezing the bag, you actually have a higher chance of squeezing too much air in that patient. And so positive pressure ventilation will decrease venous return, by increasing interthoracic pressure. That's why two-person VBM is recommended, and this is what you can see here, is the two-person rescue VBM. So in low blood flow states, the lung and the gas exchange isn't working very well, okay? So for example, if this is my alveoli here, and this is my perfusing capillary, I don't have enough blood to offload CO2. Maybe the CO2 never has enough pressure to get up to the alveoli, and what happens is if I am delivering oxygen, the oxygen might jump on, but it's not going to be delivered out to the body because there's not enough blood. So what happens when I don't have enough oxygen in my body and I have low blood flow? Let me back up. When I have low blood flow, this is a red blood cell, and on a red blood cell you have hemoglobin. And with my hemoglobin, I have oxygen attached. Oh, that's not O2, but I have oxygen attached, right? So what happens is when I have low blood flow, it actually shifts the oxygen dissociation curve over to the right, and so it decreases infinity, and so this oxygen does not want to bind to the hemoglobin. So what's happening? Here's my red blood cell, here's my hemoglobin, but guess what? This oxygen is just free floating in the blood. It's not attached to this blood cell, and that's not doing the patient any justice. So when we have decreased oxygen, increased CO2, we actually have a shift in pH. The pH will be down, and that's going to be acidemia, right? So hypoxemia with hypercapnia with acidemia does different things in the heart and in the lungs. So let me show you. So in my heart, let me just draw this heart here. Okay, so this is my right atrium. This is my right ventricle. All right, this is my left atrium. This is my left ventricle. So the blood flow is going to come in from the superior and inferior vena cava, and it's going to come into the right atrium. It's going to go down the right ventricle, and it's going to come out the pulmonary artery, and it's going to go to the lungs. Okay. From there, it's going to come all the way back around, get oxygenated by the capillaries, and then it's going to come in through the pulmonary vein, through the left atrium, through the left ventricle, and then out through the aorta. So here's what happens. When I have a low blood flow state, what happens is in the lung, I actually will, here's my lung, I actually will constrict my blood vessel. It should be this, but my blood vessel ends up being like this. So what happens? I'm not delivering the amount of oxygen I can, if I even, in offloading the amount of waste, because I should be able to fill this up here. But now I resist it, so I'm not getting the same amount of flow. The pulmonary vasculature actually increases resistance when you have a low blood flow state, and also when you have decreased oxygen and high CO2. On the heart, when you have high CO2 and decreased oxygen, you decrease systemic vascular resistance. So what does that mean? That means that your aorta and all of your arteries, instead of being normal in size, they become big in size. And what are we trying to do? We're trying to up the blood pressure. How can I up the blood pressure if I'm vasodilating? So that's why CO2 differences with oxygen differences, they act differently in the lung. So if you remember, blood pressure, which is what we're trying to do, we're trying to restart the heart, we're trying to increase that blood pressure, right? Blood pressure is the product of cardiac output and systemic vascular resistance. So systemic vascular resistance means, am I dilated or am I constricted, right? But my cardiac output is achieved by my heart rate times my stroke volume. Well, in cardiac arrest, what don't we have? We don't have a heart rate. But let's say I do compression, so I'm going to try to get a heart rate of 100. My stroke volume, we already said in that circulatory phase, right? Beyond that 10 minutes, we don't have any stroke volume. So guess what this is? Almost zero. So it doesn't matter what my heart rate is times zero, that takes out my blood pressure. So we try to infuse some fluid. So now we got the heart rate going at 100. Let's say we're infusing some fluid. So let's say the stroke volume is okay. Now what happened? The oxygen, the increase in carbon dioxide and the decrease in oxygen, what is it doing to my SVR? It just dilated. So if this side goes down, what's going to go down? My blood pressure. So that's why it's a fine tuning and a fine game of trying to figure out the right balance of oxygenation, carbon dioxide, and compressions with fluid and drugs to try to make all of this work. Now, we do have other drugs that will increase my SVR, which is epinephrine, because of the alpha-1 properties, but we're going to get into that later. But it's a fine balance, and we have to actually become experts at this if we want to try to get to patients to go home. So when we talked about the hyperventilation, so what I want to do here is just very briefly, right? This is my lung, and of course, this is my right side, and this is going to be my left side. But over here, what happens is I have a cutout for this heart, right? Because my heart lies right over here. So when I take this and I kind of turn it sideways, and what I'm going to do is I'm going to try to show you as best as I can a 3D representation here. This is going to be my lung, okay? And here's my cutout for my heart right here. And then this is my left ventricle. So when I inflate my lung, this area here is going to get bigger. And when it gets bigger, it's going to expand when I inflate, whether ET tube, BVM, whatever reason, it's going to inflate. So now what just happened to the chamber and the diameter of those left ventricle is supposed to pump blood all the way, or pump blood to the rest of my body. It just got smaller. It just got smaller because the lung is now taking up all this. So I've decreased my left ventricle size, the amount of blood that I can actually fit into that. So airway management, there are programs out there and protocols out there that talk about passive oxygenation. And what that would be that if you're in that electrical phase, and we already talked about, up to the first 9.5 minutes, you can actually have enough SpO2, or I'm sorry, enough oxygen in your body to have an SpO2 of 93%. Some protocol systems out there, if you have a primary cardiac arrest from a cardiac etiology, will say just put the patient on a non-rebreather 15 liters per minute. Those who don't advocate for that actually will just say use a BVM. If you're getting compliance, great, stick with the BVM. The one downfall from the BVM is you can have gastric inflation by hyperventilating and pushing too much air in. And then eventually they say, go ahead and put an advanced airway in. So I just want to show you on the right-hand side, an advanced airway is either an endotracheal tube, it could be a King airway, and it can be an iGel or whatever rescue supraglottic airway you have. If it's an LMA, we can put that in there too. So a lot of systems are saying, just go ahead and put in a King airway, go ahead and put in an iGel, and that'll work as an advanced airway. When you get to the ER, sometimes the resuscitation team does not like those devices, and they will go ahead and put in an ET tube. But they're in a more controlled environment, and they have tools readily available with a whole team of anesthesiologists and respiratory therapists. The advanced airway, like I told you, is either one of those, the ET tube, the iGel, or the King airway. And in 2018, there was a study published in Critical Care Journal that they compared 3,000 patients with cardiac arrest. They compared the King airway to the endotracheal tube. And the King airway had a higher first-time success rate. King airway had a higher percentage of return of spontaneous circulation. The King airway had a higher hospital survival and discharge, and also had a higher favorable neurological outcome. So I'm going to pose a question. Why do you think that is? If you want to answer, go ahead. If not, okay. Well, the reason for that was we didn't stop compressions in order to put this device in. Same thing happened with the iGel. The iGel also outperformed the ET tube, because I'm sure we've all been on that cardiac arrest where somebody at the airway says, stop compression so I can look at the tube. And then guess what? It goes on and on and on and on. And the amount of delay is about 72 to 90 seconds that it takes to get that airway. And that patient is not getting perfusion while you're trying to get that airway. That's why the advanced airway is now equivalent between the ET tube, the King airway, the supraglottic, and the iGel. Also, we talked on the the second session about the percent of first-time ET tube innovation for EMS versus doctors. And EMS was in the low 70s, and physicians in the emergency room was only about the 80s. So it's no surprise why a lot of programs are shifting their treatment from ET tube to supraglottic airways. There's something that's recently come up, recently within the past decade. It's called an impedance threshold device. And so what happens is it's this little device right here. And what happens is you put that in line between either the mask or between the bag and the ET tube. And so what happens is it creates negative thoracic pressure. And so what that does is it allows the air to exit during chest compressions, but it blocks airflow back into the chest during recoil. And so what does that do? It allows for increased venous return, increased blood back to the heart. So position of AED pads. So historically, the position of the AED pads was the right anterior chest and then the left axillary region. So we would have one here and two here. And so the idea for that was that the heart, this is a pad here, this is a pad here. It's supposed to be a square. This is the heart. The idea was that the electrical energy would come through here in this vector in order to try to stimulate the left ventricle or the ventricles to stop fibrillating or quivering in order to get regular beats back. But that's only one vector. So new research came out and says, well, maybe that's not the right one. And if you ever taken somebody into the cath lab, you've taken somebody, a chest pain, to the emergency department, and they go ahead and they put on AED pads before you even got to it, they're doing anterior posterior because they thought, well, now what if I am not doing the vector right? And now what if the anterior posterior pads are better and they're going to send electricity from the front to the back like this, and that's what I need. So then comes the idea, well, let's change the vector. Let's change the vector on cardiac arrest patients by putting 4 pads on. So what I'm going to tell you, if you are in a protocol system that allows you to put on four pads or 2 sets of pads, the first 2 pads you want to put on is the anterior and posterior pad. Okay, so put the anterior or the posterior pad on first, and then put the anterior pad on second. And the reason is because once you start chest compressions, you don't want to interrupt those chest compressions. So roll the patient to their back and put it on the back by the left scapula and roll them back, because it defeats the purposes we've been doing for the past X amount of minutes. So, and also just a little fun fact, it takes 45 seconds of chest compressions to increase your coronary perfusion pressure and to increase your cerebral perfusion pressure. So I have to start all over again for the first part of doing compressions because I've dropped that pressure and I'm not perfusing anything. It takes 45 seconds to do that. So position of AED pads. If you're in a progressive system, it allows you to change the vectors. It doesn't matter which ones you defibrillate at first, whether you go front to back or side to side or anterior, right anterior and left lateral, or anterior posterior. Just know that eventually after the 3rd shock, you're going to switch that up and you're going to come at it from a different way because we don't know which cells are ectopic and which ones we need to settle down in order to get the heart perfusing better. Then if you're in an even more progressive system, like we are here at Trumbull Regional, you're going to do double sequential defibrillation, which means we're going to light this heart up from all sides at the same time. And we're going to get into that later on. But first, let's talk about some pharmacology. So our king of drug is going to be epinephrine. And, you know, there's a bunch of research out there that doesn't even know if epinephrine works, but we've been doing it for so long and we know the properties of epinephrine that we're going to continue to do it. So pharmacodynamics, and what that means is how does this drug work? Well, the drug has alpha 1, alpha 2, beta 1, and beta 2. And what that means is alpha 1 and alpha 2 are adrenergic receptors and it causes vasoconstriction. So over here, this is the abbreviation for alpha. So alpha equals increase systemic vascular resistance or constricts. All right. Beta actually is going to allow us to increase the heart rate, increase contractility, and it's going to kind of increase the oxygen demand so we can get the heart started again. And it's going to increase the ectopic foci to try to focus to beat in sync with each other in order to do it. So alpha is increasing the vasoconstriction, and beta is increasing everything with my heart. That's why we give epinephrine. We have alpha to constrict, beta to restart the heart. That's why. Also, that's beta 1. Beta 2 causes bronchodilation. So what are we trying to do? We're trying to get oxygen into the lungs. So wouldn't it be cool if we had a drug that also allowed us to dilate those bronchi so we can push air in? That's the other reason why epinephrine is so great. The indication for epinephrine in cardiac arrest is VFib, VTAC without a pulse, and it's also going to be for PEA, and it's going to be for asystole. The alpha stimulation causes the increase in coronary and cerebral blood flow during CPR because it's going to vasoconstrict to a point that we want. It's going to try to raise those pressures. We can also give epinephrine in symptomatic bradycardia, and that's going to be your epi push dose pressor. Or your epi drip. I prefer an epi pressor because all you do is you draw it up out of the 1 to 10,000 cardiacs or epi. You draw it up, you dilute it with saline, and you can push as much as you want. And then also we're going to give it for the same reasons in anaphylactic shock. But Joe's going to talk about that later on throughout this lecture series. The alternative to the first or second dose of epinephrine is going to be vasopressin. And really around here, I don't know of anybody who's using it in Northeast Ohio, pre-hospitally anyways. But vasopressin is an antidiuretic hormone that occurs naturally in the body. And so studies show that it actually increases vascular smooth muscle contraction, which in turn is going to elevate the SVR, systemic vascular resistance. We're going to constrict. So we're going to try to, increase the blood pressure that way and try to restart the heart with vasopressin. But the problem with vasopressin, it has a long half-life of like 20 minutes. So if you give epi first and you give vasopressin, sometimes they instruct you to wait a little bit before you give your next epi so you don't put too much load onto that heart during resuscitation. So we can use vasopressin alternatively in cardiac arrest for the first or second dose of epi in the management of VFib, pulses VTAC, asystole, or PEA. And vasopressin, the common dose of vasopressin is 40 units. And the epinephrine is 1 milligram every time we use it. Another drug we're going to talk about is amiodarone. Amiodarone is a drug that can affect different parts of the heart. It can actually act on the sodium channels. It can act a little bit on the potassium channels. It can act a little bit on the calcium channels. So we can use this in a wide variety of contexts and reasons in EMS, but specifically for cardiac arrest, what it's going to do is it's going to allow those ions to go across the cellular wall during depolarization. Right? It's going to inhibit the abnormal automaticity. So when we talk about VFib and we give 300 milligrams of amiodarone, it's going to prevent that cell from firing on its own without being stimulated by a previous cell. It prolongs the refractory period of conduction, which means that if I go ahead and I squeeze my heart, and then while my heart's trying to reset the squeeze again, instead of maybe every second, it's going to wait every 3 seconds to reset so it can contract again. Right? It's also going to slow the sinus node discharge and the AV node discharge rate. Okay, things we want when we have a heart rate that's too fast, it's going to try to slow that down. So when is it indicated? It's indicated in supraventricular tachycardia, such as AFib with RVR. It's also indicated in VFib and pulses VTAC. We can also give it in VTAC with a pulse, which is stable VTAC, and we can give it, that's also known as Y-complex tachycardia. Usually comes pre-hospitally in 150 milligrams and 3 mLs. So for what we're going to use it for pulses VFib VTAC, our first dose is going to be 300 milligrams. Our second dose is going to be 150 milligrams, and then no more. If you're using it for somebody who actually converted, then you can make a drip, and you would make a drip by taking 150 milligrams, put it into a small bag, and reconstitute that. And you could do 1 to 4 milligrams per minute. Lidocaine. Lidocaine actually decreases the automaticity of the heart, which means it's not going to be excited by its own. It decreases conduction of velocity through the ischemic tissue, so it's actually cardioprotective. Right? by being cardioprotective, we're going to increase the VFib threshold. And if I increase the threshold in something, that means it's going to take more effort to try to make it do what we're trying to prevent. So what it's doing, it's increasing the threshold, which means the heart is not as likely to go into fibrillation after conversion if we give the lidocaine. So that's how that works. Right? So the indications is when we have PVCs, when we have persistent to recurrent VFib tach, and some wide complex tachycardia, and it's either or. So it's either amiodarone or it's lidocaine, but not both, because the studies out there suggest that if I just gave amiodarone and then I back it up with lidocaine, and I've just now suppressed all ventricular function for a long time. And the average half-life of amiodarone is about 40 days. So that's going to take a long time to get out of the system if it doesn't need to be there. And by that time, the patient will have expired and probably been buried by then. So also, I told you that lidocaine is preferred in pregnant females, and I'm just going to use this universal symbol for female. So please remember that so it doesn't affect the developing fetus. Atropine. Atropine blocks acetylcholine receptors, and it inhibits parasympathetic effects. I've heard over my career and by many students that I'm going to give atropine to speed up the heart. And although it indirectly works like that, that is actually not how it works. So what it does is we're blocking something in the body that's causing the heart rate to slow down. So we're blocking it. If I give atropine and there's absolutely nothing in the body that's slowing the heart rate down, atropine will do nothing on the body to speed the heart up. All right. So atropine blocks anything in the body, specifically parasympathetic discharge, so that the heart can naturally start up on it, increase its heart rate on its own. Also, it's going to improve AV node conduction, and it reduces the chances of ectopic beats. What are the indications? Well, symptomatic bradycardia, and we told you for 2020 guidelines that it's going to be 1 milligram every 3 to 5 minutes, and a max dose of 3 milligrams. So when you have somebody who is bradycardic and they have a heart block that's either a second degree type 2 or third degree heart block, it doesn't work. So there's no point to even draw it up. And why doesn't it work? Well, here's my heart. Okay. So what happens, this is my SA node, this is my AV node, SA, AV, it comes down to the bundle of His, comes down and it wraps around to the Purkinje fibers. I promise I'm not drawing a cat. So then what happens is when I have a second degree or third degree heart block, what did we just say? We said that atropine increases the AV node conduction. But in the heart block, second degree or third degree, second degree type 2 or third degree heart block, there is complete disassociation from the SA node down to the ventricle. So that's why you'll have an atrial rate or a P wave that is more than your SA node will fire at normal 60 to 100 beats per minute, and your ventricular rate or your QRS will be firing between 20 and 40 per minute. There's absolutely no way that I can speed up or slow down the conduction for that because there's a disassociation there. So I can't speed that up. So giving atropine to somebody who's in peri-arrest because they were in a heart block is not going to do anything. The best thing for these people are to pace them. All right. We give it for organophosphate poisoning to reduce the sludge symptoms, salivation, lacrimation, urination, diarrhea. But we no longer give it routinely in cardiac arrest. And so it used to be back in the 2005 guidelines when I went to paramedic school, and that's what I learned, was that you give 1 milligram of epi, wait 3 to 5 minutes, give some atropine, wait 3 to 5 minutes, give some more epi, and that just didn't work because of what we now know of how the drug works. All right, mag sulfate. Magnesium sulfate, how that works is it blocks calcium channels. All right, so if I kind of block calcium channels, I'm not going to excite anything. So the number one electrolyte to stimulate the SA node is calcium. Calcium works on the SA node to increase the heart rate. And sodium works on the ventricular function to increase contractility. So what happens? If I block calcium, I'm not increasing my rate. That's pretty self-explanatory. When do we give it, though? We give it in something that's called torsades. And in torsades, you have something that looks like VFib, okay? And then all of a sudden, you'll have more stuff going down, more rhythm, depolarization going down, and then all of a sudden, you'll have higher rhythm going up, and all of a sudden, you have lower rhythm going down. And so right here, you're going to see a twisting of the points here, where primarily this is going down, primarily this is going up. And that's really the definition of torsades, where we have a twisting of the points, and normally that's caused by magnesium deficiency. We give mag sulfate comes in, we block the calcium channels. This is all super excited cell. These are all super excited cells. So we decrease the calcium, we decrease the firing of the cells, we decrease the SA node rates, and we hopefully get these people back into sinus rhythm. And normally our dosage is 2 grams. Sodium bicarbonate, it's a hypertonic solution, and what it does is it replaces sodium and bicarb, hence the name sodium bicarbonate. It also bronchodilates, suppresses the CNS, and it works as, and by doing so, it works as an anticonvulsant. And we used to give this up until the 2015 guidelines. We used to give this pretty regularly towards the end of a cardiac arrest to try to get that patient to go from an acidotic state to a more normal state. So when we talk about pH and acidotic, we know that the normal pH of the person is about 7.35 to 7.45. All right. When I'm acidotic, I'm over here, which means I'm less than that. So let's just say 6.0. When I'm alkalotic, my pH is higher. So let's just say 7.6. Or let me just use whole numbers here. Let me say 8.0. So what was happening is we were taking a patient that we knew was down here because they weren't breathing right? Because what happened? Decrease oxygen, increases CO2, and what does that do? That decreases pH or makes them acidic, right? That's where we were. And then so we would go from this acidic state all the way to an alkalotic state, which is just as bad. That's like giving somebody back in the day, somebody who had a sugar of 40, a whole amp or 25 grams of D50, and what did you do? You put them into borderline DKA because you rose it from 50 all the way up to 300. Okay, I fix you. Call your doctor. Goodbye. Right? So that's what we were doing. That's why it's no longer indicated in routine use of cardiac arrest, because we're going from the acid side to the alkalotic side, and it's very different. What are we going to do? Stop breathing for the patients? Nope. How are we going to get that patient to become more acidotic? Think about that, right? So we moved in with the other spectrum. So we really don't use it that much. They can use it in hyperkalemic or kidney failure, renal failure patients, people with a prolonged downtime with nothing being done with them. So most boxes would say, most protocols would advocate for 1 milliequivalent per kilogram, but a lot of boxes are only putting 1 box in there, 50 milliequivalents. And everybody's asked me over the past couple of years, well, Larry, why do we only put 1 box in there when it's 1 milliequivalent per kilogram? Well, because we don't want to go here. We want to be here. And that's why. Okay. So I'm going to continue to go on for a little bit, and we'll take a break here. I think we started around 6:20, so I'm going to go for a couple more minutes here, and then we're going to take a little bit of a break. And then I'm going to hopefully finish strong so that Dan can start his lecture and we don't have to be here past our normal time because Joe's not lecturing today. So let's move forward. All right. So with cardiac arrest, the general approach is we're going to check the responsiveness of a patient. Remember when we learned in CPR, Annie, are you okay? Well, whatever we got to do to get that patient's attention, are they okay? We're going to check the responsiveness. Then we're going to check for signs of normal breathing. And the American Heart Association is emphasizing that agonal breathing or gasping breathing is not normal. And we know that, but the average person does not know that. So we need to make sure that when we educate people and when we do these community CPR things, or we're teaching these CPR classes, that we actually say, Gasping breaths are not normal breaths. And if you're assuming that they aren't breathing right, or there might be some question that they're not breathing right, they're probably not. Go ahead and start chest compressions. We're going to check for a pulse for no longer than 10 seconds. We're going to start the chest compressions, and we're going to apply the AED pads. So in here, you really need to focus on the pit crew or the team focus or team-based CPR, and we really need to start establishing this. And I know a lot of regions, a lot of areas have a tiered response. So maybe you're in a township. I know we have people on here from Vienna Township. So Vienna Township, actually, their police department, they go on every medical call, and they will get in and get just as dirty as the EMS crews. So those police officers will actually, because they're more centrally located and there's more of them, they can actually get to calls quicker, and they drive faster, and people pull over for them. But they get there quicker, and they can actually start compressions. And we know that compressions and early defibrillation is something that we need to do in order to increase the chance of survival, especially up to the 5-minute mark of cardiac arrest. So what I want to kind of show you here is this team-focused or pit crew CPR algorithm, little diagram. So what we advocate for is whether you're BLS, ALS, right, whether you're police or fire, we want to look at these positions here. So I'm going to start over here. Let me get a different color other than. So I'm going to start over here. And so BLS position 1, that's the person who walks through the door, they check the responsiveness, and then they're going to start beginning compressions, right? The second person is going to walk over here. They're going to get on the other side of the person. They're going to attach the AED. Notice we haven't done anything with the airway yet. The third person, based on their protocol, they're either going to insert the OPA and start ventilating. This is provider number 3. Or if they're doing cardiocerebral resuscitation, they're going to put on a non-rebreather 15 liters per minute and apply end-tidal CO2. And these 3 people will actually do effective resuscitation if they need to. So positions 1 and positions 2, these 2 people will actually swap out CPR every 2 minutes, or chest compressions every 2 minutes. This third person here is going to either ventilate or they're going to apply the non-rebreather. If they apply the non-rebreather, that frees that person up for CCR to come down here, or that fourth person rescuer can come down here and actually either interpret the monitor if they're a paramedic, okay, or if they're also a paramedic, they can try to start the IO. So either way, you can either do the monitor or do the IO. If you insert the IO or the IV, you're going to be the one pushing the medications, and you're not going anywhere. You're going to be stuck there pushing those meds. Because why am I going to take a person here who knows every drug I gave and how quickly I gave it and when it needs to be done again, and move them up into the compression role, because they're not going to have any idea, and that person coming down here to do from compressions is just going to get most likely overzealous and push those meds, right? So as you start to build your team, first person looks at the monitor, verifies pulse checks in between. They're going to defibrillate if they need to. The other person is going to do the IVIO and medication access. Then we're going to have somebody up here, maybe a skilled provider, and that person is actually going to manage the airway or manage these 3 people taking care of the airway and compressions. We're also going to have somebody, if we can, in a perfect world down here, have somebody monitor the overall success and the changing of the people. And I know we don't carry stopwatches, but we all have phones. Go ahead and hit that timer and look at that timer. And every 2 minutes, 2, 4, 6, 8, right? Have these 2 people switch compressions. We should also have another person. And I know some departments have chaplains. I know that maybe some EMS supervisors or the fire captain will come, and they will talk to the patient's family. And that patient's family, don't be quick to rush them away from what's going on, because they need to be part of that care team too. They need to know that fire, EMS, and the police department are doing everything they need to do. Now, if they don't want to see it, that's one thing. But chances are they want to see it and make sure everything's going on. So ask them, do you want to see this? And explain to them, if they do stay, this is what's going on. Right now, there's no electrical activity of the heart. We're pushing medications. We're doing everything the ER can do. And that leads to like a 30-second rant. Why is it that we're so in a hurry to get the patient who's in cardiac arrest in the back of an ambulance, and go lights and sirens to the hospital when we can pretty much do everything the hospital can do when it comes to basic cardiac arrest management? And all the algorithms are basic cardiac arrest management. Why is that? If it's a traumatic arrest, it's something else. But last time I checked, and it's been a couple years, CPR in the back of an ambulance moving 60 miles an hour is probably 13% effective. I don't have the latest research on that, but I do know it's low. And you got to remember, if you're doing manual compressions and you're pushing down 2 inches on that patient, that mattress on that cot is also pushing down 2 inches. A little bit different if you have a Lucas device or an automatic CPR machine, but still, we want to make sure that everything's being done. So we always advocate for working that patient where they're at, working that patient in the middle of their living room. Unfortunately, if it's in a store, we're going to clear out that aisle of that store, and we're going to do the best for that patient. Because think about the last cardiac arrest you ran. When you move that patient, was somebody always on that chest? If you have an automatic CPR, Lucas device, or any other sort of like auto pulse, maybe, yeah, you had it on there. But then think about, what about if you're doing ventilations? Did you let that tube fall off to the side? Did you disconnect that BVM? Did you swap over the non-rebreather with the oxygen? But again, we're so focused on getting in the back of the ambulance and running lights and sirens to the hospital. We are the experts here. We're the experts when it comes to cardiac arrest, and we need to respect ourselves when doing so. Okay, so we spent a long time talking about cardiac arrest and what happens, and we even mentioned primary cardiac arrest with cardiac etiology. And so what we assume from that is that primary cardiac arrest from cardiac etiology is pretty much having a heart attack that caused you to have sudden cardiac arrest and drop. We said earlier that 70% of everybody who went into cardiac arrest was found to have ventricular fibrillation. We also talked about that early defibrillation, early CPR is something that we need to have access to, and that increases ROSC rates. But right now, we still have to do a better job educating the lay people and the hands-only in this community CPR to do better. So what we're doing in January is Stewart Healthcare with Trumbull Regional Medical Center and Sharon Regional Medical Center is we're going to the fire departments in our communities, and we're joining with them, and we're bringing all of our CPR instructors, and we're going to train the communities for free on how to do hands-only CPR, because we believe, as the only cath lab in Trumbull County, that we need to have bystander CPR, and Sharon also is a cath lab. So we'll come down to Mahoning County, we'll go to Columbiana, we'll go wherever's needed to get this CPR, hands-only CPR out there. So that's our commitment, and also in 2022 is to increase the amount of hands-only bystander CPR for the communities, and Stewart's going to take on a large project with that. So the other thing I want to say is that's one way we're fixing the bystander CPR locally here. The other thing is, if your police department, if you could train your police department in compression or in CPR, and maybe see if they can buy their own AED, or I know that some agencies and some foundations have bought AEDs for police departments, have them at least one AED in the back of an on-duty car. That way they can get to that scene maybe quicker than the fire department, or maybe quicker than that third tier response from that ambulance company. In order to apply that, that's how we're going to have the better out-of-hospital cardiac arrest survival rate. So there are things we can do locally. If you want to team up with us, we're more than happy to try to make that possible, whether you're under a protocol or not. And we want to have the best outcome for the patient every single time. But let's go back to the cardiac etiology. So most of these patients, they usually complain of chest pain leading up to it. And chest pain is going to be from a myocardial infarction, and that's going to be from a clot that wedges itself into a coronary artery. And that part of the heart is not going to get perfused. So eventually, without treatment, that patient's going to go into cardiac arrest. Again, most likely VFib, because the cells are going to be ischemic, hypoxic, you're going to increase the CO2. You're going to have that decreased SVR in the heart. So we need to act quickly. But before we get to that, I think it's worth talking about the acute coronary syndrome. And so that's going to be your patient with chest pain, and it's going to be cardiac in nature. So obviously what we want to do is we want to come in and we want to talk to the patient and get a history of what's going on. What's important is it's important to get that aspirin on board very quickly. AHA and everybody around the country agrees that 324 milligrams of aspirin given orally is the best thing for this patient in order to prevent platelet aggregation. So aspirin works on a TXA2 receptor, and that TXA2 receptor acts as a beacon to say, hey, other platelet, come over and attach to me. So we can block that, then we can kind of block more platelets from sticking together. So locally, we've given ourselves a time frame of 3 minutes of patient contact. Hey, you have chest pain, tell me about it a little bit. All right, one person's assessing the patient, the other patient's getting that drug box, and they're giving aspirin. So aspirin in the state of Ohio, we use everything color-coded here. So EMR is going to be gray, EMT is going to be blue, advanced is going to be green, and paramedic is going to be red. So give yourself a goal. If you're doing protocol work, or even when you get on the ambulance, give yourself a goal to give that aspirin as quickly as possible and get that on board. The aspirin should not be given after the patient is loaded up in the ambulance and you're on your way to the hospital. They have chest pain, go ahead and give it to them. And I'm going to go one step further. If they say they've already taken aspirin at home, we're going to give them our aspirin. And the reason we're going to give them our aspirin is, one, an additional 324 milligrams of aspirin is not going to do anything to that patient, but err on the side of caution that they need the antiplatelets on board. So most people keep medication in a bathroom and a sink. Most people keep it in their kitchen next to the sink. They're changing humidity and changing environments with heat and cold, and they don't really have them regulated as best as we do, or what the hospitals do. So aspirin can change its potency based on humidity and based on dark, light, cold, warm environments. So give them aspirin, give yourself the goal of 3 minutes. If you can't, get it as quickly as possible. Even if a patient has an ulcer, the aspirin, the risk outweighs the benefit. I'm sorry, the benefit outweighs the risk. The benefit of giving the aspirin on board outweighs the risk of having that ulcer become upset. All right. So give the aspirin. Because we want to anticipate what's going on, we're going to go ahead and apply that nasal cannula and tidal CO2, and most of these will be able to deliver oxygen. And research says that because of free radicals, we want to titrate the SpO2 to 90%. So if the patient's at 91%, they're complaining of chest pain, we're not giving them oxygen. And then give yourself a goal. If you can give aspirin in 3 minutes, go ahead and get a 12-lead within 5 minutes. See what's going on. And 12-lead placement is key. And maybe we'll do a local lecture on chest pain and how to do 12 leads and advanced 12-lead interpretation. So go ahead and do that 12-lead. As soon as you look at that 12-lead, we should be transmitting that to the facility. So regardless if it's a STEMI or not, regardless if it's a heart attack or not, all cardiac events should actually get transmitted to the hospital. So locally, there is a system that's out there with Stryker and Physio through LifeNet, and that's very popular. Locally, we use an app called Triage, where we could take a picture, send it, and when we send that picture, like here at Trumbull, when we send it to Trumbull or we send it to Sharon, those pictures actually go to the cardiologist as well. And the cardiologist on call, the interventionalist, and also the cardiology manager, the nurse manager, get those pictures. They can then activate the cath lab from their home or from their office and get en route to the hospital before the EKG doctor, before the ER doctor even looks at it. So depending on how your system's hooked up and how they do that, try to advocate for transmission of all cardiac events to the ED, because maybe it's a complex case. Maybe we don't see something and the experts do. So go ahead and transmit the EKG and notify the facility early, especially if you have a STEMI, because sometimes at night, these patients, in these smaller areas, even though they have a cath lab, they have a 30-minute window to get to the cath lab. So more of your larger academic centers, they're going to have people who have overnight rooms, and they're going to be able to accommodate you whenever you walk in. But based on where you're at, advocate for those three things. Aspirin within 3 minutes or as quickly as possible. Your 12-lead within 5 minutes or as quickly as possible, and then send that EKG off just to make sure you didn't miss anything. So let's go down the left-hand side, because your STEMI is what's going to lead to cardiac arrest if it's not handled in time. So one of the things that I want to kind of caution you on is an inferior wall MI. So typically if the patient's bradycardic, that's a good indicator, and they have chest pain, that's a good indicator that there could be an inferior wall MI. All right. So in the past, they said, go ahead and move V4R. So take that fourth electrode, move it over to the right side and just mirror it and see if you have any ST elevation on the V4R one. And the reason for that was because they wanted you to be cautious with nitroglycerin because they thought you could bottom out the blood pressure. Well, after research, they actually finally found out that the chances of nitroglycerin bottoming out the blood pressure in inferior wall MI, if it is right-sided, is very low. Because if it was something for concern, why would these patients with chest pain be prescribed nitro at home? And guess what they're taking when they have chest pain? Nitro. So we're moving away from old stigma and we're moving towards a new medicine and based on research. So be cognizant of that inferior wall MI and move forward. Don't withhold the nitro. Don't withhold the aspirin. All right. So obviously, let me back up one step. If the blood pressure is 100 or less, or based on whatever your protocol is, then obviously you're going to withhold nitro because it's going to vasodilate and it's going to cause a drop in your blood pressure. So be cautious of that. Hard stop, whatever your protocol is. So for us, we're going to apply the AED pads in the anterior posterior position. And earlier in the lecture, I told you about anterior posterior position because if the patient does go into cardiac arrest, we don't want to take our hands off the chest, roll the patient, put them on, especially if they go into some sort of VFib, which we now learn that is between 0 minutes and 5 minutes of that cardiac arrest. And we might have to do a vector change or we might have to do double sequential defibrillation. So AED pads will go in anterior posterior position, and most cath labs like them there anyways. Then we're going to give Brilinta. Now, Brilinta, depending on your system, is controversial. So the Brilinta is another platelet inhibitor. And at last, any platelet inhibitor is going to affect it, whether it's aspirin or whether it's Brilinta. It's going to stay in your body for about 7 days. The interventional cardiologists who do the stents, they love it. And the cardiothoracic surgeons who do the bypasses, they hate it. So the medical director, the cardiac team, and the protocol system that you work under, we'll all talk about this. And it's specific, I guess, for some regions, like up in the Cleveland area. Which cath lab you're going to is if whether or not you're going to give Brilinta. So ticagrelor is the generic name of it. If you're giving it, it's 180 milligrams given by mouth. You pop the tablets in, you have them chew it up, only if it's a STEMI, all right? So we want to be able to do that on scene, and we want to have rapid transport to the hospital to a cath lab. Hopefully 10 to 15 minutes is our on scene time. Obviously, give the nitro. And again, don't withhold the nitro just because you don't have an IV. That's bad practice. We know that if you have a systolic blood pressure of 100, giving one nitro probably isn't going to drop it to the fact that the patient goes into PEA. All right, so go ahead and give that nitro. While you're en route to the hospital, we want you to establish an IV, preferably on the left side, because they usually, if they're doing radial catheterizations, they're going to do it on the right. Draw some labs if your protocol system allows you to do it. For some reason, if you have a cocaine-induced STEMI, go ahead and give some Versed IV or IM. And then heparin. Heparin is usually a pretty good thing to do. Going to give some 60 units per kilogram IV, IO. And usually the max stop of that is around 4,000 units, at least locally here. If you need to go ahead and control that nausea, we're going to control it with some Zofran. All right. And you see what I didn't put in there, I actually left that box blank, is fentanyl. Previously, we would say give fentanyl, but because we're giving Brilinta, fentanyl decreases the absorption in the stomach of Brilinta. So if we give fentanyl to a patient, we know that when we give them the Brilinta, it's not going to absorb. So the 180 milligrams that we're absorbing is we're not going to get the effect that we want. So we're in talks with our cardiologists to change it from fentanyl, which is really only given to kind of help ease the pain and reduce a little bit of anxiety. We're going to talk about giving, intravenous Tylenol, also known as APAP. That's the medical abbreviation. All right, so that's kind of cool. That's interesting. That's new research. And as soon as the research comes out, we can verify it. We're changing it here at Trumbull. If you have a chest pain or non-STEMI, give nitro, do your normal stuff, give it the Zofran, and it's okay to give some fentanyl because you're not getting antiplatelets such as Brilinta. And again, if you need to give some anxiolytics such as Versed, go ahead and do that. All right, this is just a 12 lead. We're going to have an advanced 12 lead cardiology class later in this refresher, I hope. So we're going to skip over this. So bradycardia. Bradycardia can be from an inferior wall MI, and it can also be from somebody who's actually, has some sort of right coronary artery. The right coronary artery perfuses the SA node. So if I have some sort of inclusion there, bradycardia means it could be impending cardiac arrest. So with bradycardia, we're going to do, titrate some oxygen levels up to 94%. And we want to confirm that the pulse is actually less than 60, right? Do your 12 lead, transmit it as soon as possible. Apply your AED pads in whatever position the protocol says. Locally, we're going to do anterior, posterior, because what if we have to do double sequential, change that vector? All right, get the AED pads on. Even if it's not a STEMI, you're going to put those AED pads on in preparation. You're going to get your IV. And if they're stable, we're just going to watch them. All right. People who are athletes have resting heart rates of like 40 to 50, and they're perfectly fine. But if they're unstable or they're symptomatic, then we need to kind of, intervene. So there's a mnemonic that was, I was told by my paramedic instructor, Randy Benner, that this mnemonic, CHAP, was invented at YSU. And any standardized test you take, whether it's your boards for medical school, the USMLE, whether it's your boards for nursing school, the NCLEX, whether it's your paramedic national registry exam, they're going to question, or your ACLS exam, your PALS exam, they're going to question you on what should you do? Should you give medication or should you do electrical therapy? And I'm here to tell you that CHAP always equals electrical therapy. Okay? So over here, you're going to see the C stands for chest pain. The H is going to be hypotension. The A is going to be altered mental status, and pulmonary compromise or hypoxia or trouble breathing is going to be the P involvement. So CHAP, that's how you know go right to electrical therapy, depending on how bad it is. Now, maybe they're a little shorter breath, but their pulse ox is in the tank. You can go ahead and you can do some medication. But on any standardized exam, if it's CHAP, you're going to go ahead and either pace them or light them up, depending what the situation is. So let's say that they're stable, but you want to kind of increase that heart rate. So we can give 1 milligram of atropine, as already previously talked about. We're going to give it every 5 minutes in our protocol, and the max dose is going to be 3. If that doesn't work, you can switch to an epi push dose pressor. 0.5 to 2 mLs of an epi push dose pressor is going to be 2 to 10 mics, and we're going to do that every 2 minutes. If you need to sedate them because you're going to do some stuff, then what we're going to do is because the patient if the patient has a normal tensive blood pressure, we're going to give them some Versed to offer maybe a little bit of amnesia for if we do have to pace them. And if they're hypotensive, don't be afraid. Go ahead and give them some fentanyl. Right? When you do pacing, compressions and defibrillation are what makes the return of spontaneous circulation better. Doesn't matter the amount of epi you get on board. Doesn't matter if you have a fancy automatic CPR machine. It doesn't matter if you have a video laryngoscope. What makes it better is early effective compressions combined with defibrillation, and that's going to be the best thing. So we need that person to say, okay, maybe it's time to switch. I noticed that you're getting a little bit tired. Let's go ahead and switch out. And anybody who's ever been in a cardiac arrest with me, I'm pretty adamant about switching out. And I actually have my team actually count down and say, okay, I've got 50 more. I've got 30 more. And when I get down to the 10, I'm counting out loud so that I'm going 10, 9, 8, 7, 6. So that when I get to 3, 2, 1, the person directly across from me is ready. As soon as I pick up my hands, they're ready to come down onto that chest if we're doing CCR, and we don't need to check that rhythm.
Well, hello, everybody. Thanks very much. And I want to say, Larry, great talk. I really enjoyed it.
You muted yourself, Dan.
You're good, Dan. That was us on our end.
Oh, okay. You got me now?
Yep, all good.
Okay, great. I was just going to say that was a great talk. Thanks very much. A nice comprehensive review. And I was also pretty happy to hear a number of points that are going to carry over into my talk as well. I like it when I can always repeat what smart people say. I was planning on having Mistovich talk before me, so I didn't really prepare any material tonight, thinking I was going to have about 14 minutes worth of stuff to be able to present and then just go home. But I'll do my best to stretch out what I've got. I want to talk tonight about post-arrest care. But before I get started, and as I always mention before I start my talks, I'm a big believer in the free open access medical education movement. The notion being is that we should be working together to make each other smarter. We should be sharing good ideas. We should be taking material and passing it among us to elevate our profession. And that's really what I'm here tonight for. My intention is to make you smarter. And if any of the materials that I present to you would be helpful to you, all you have to do is let me know. I'm happy to share anything and everything that I've presented tonight. I also appreciate that I talk kind of fast and I click through some of the references too fast to write them down. All you got to do is let me know and I'll be glad to share it. This is my email address and my Twitter handle. It'll be up at the end of the talk too. But like I said, if you want any of this stuff, just give me a holler and I'll be glad to share. All right, so we talked about this earlier, and I think it's a really important and relevant fact: 356,000 out-of-hospital cardiac arrests. And what's really important for me is that after chasing this dog for 50 years of EMS, still 9 out of 10 of these cardiac arrests are fatal. 9 out of 10 people never leave the hospital; they never leave their house. That's something that we've been trying to fix for a long time, and Lord knows we have done a lot of work on this front. We certainly talked about it in the last talk. I'm a big ardent believer in the Resuscitation Academy and the work that guys like Mickey Eisenberg have done out in Seattle. In fact, by the way, if you've never read his book, it's still available. He still publishes a PDF form of this book every year and revises it, and it's available to you. You can download it and read it for free. And this is the guy, these are the folks in Seattle who've really invented pit crew CPR, invented high performance CPR. And I think it's really relevant that we keep this stuff in the front of our brain. I'm a big ardent believer, and I certainly understand that I've taken the lessons of early shock and early CPR, and we certainly have linked that together to outcome success. We've certainly embraced the notion of reducing pauses in shocks and thinking about compression fraction and all that kind of stuff. And certainly the lesson that we just had embraced that, and I think we're all in that mindset. And when we think about that kind of stuff, when we think about cardiac arrest, we're planning for pit crew CPR and making the leadership the triangle of life and thinking about leadership and all that kind of stuff, and we're practicing it with feedback devices. And certainly here in Vermont, we've protocolized many of the things that we've just discussed. We've sort of put all this stuff on paper and really applying it, and we're seeing great results. I'll tell you that the little town of Richmond, Vermont, which when I say it's a town, it is like a one-horse, one stoplight, one gas station town. They did 10 cardiac arrests last year, and they resuscitated 7 people. 7 people walked out of the hospital last year. So we know this kind of stuff works, but where I think we should be a little bit concerned is that everything that we're talking about with cardiac arrest is this, right? It's about the actual arrest phase, and it's about the shockable event and all this kind of stuff. And I think sometimes we forget to get into what happens when we see this, right? When we see a rhythm, an organized rhythm, and we take a pulse, and all of a sudden it's there. And I kind of think about that a little bit like it's my dog when oops, sorry, hang on one second here. I think about that a little bit like it's my dog when he's chasing a squirrel. We kind of don't know what to do when we finally catch it. We don't know what to do when that rhythm actually comes our way and when things go together. And look, I'm happy that we have this moment of success, and ROSC is a really great thing, but ROSC isn't really what the ultimate outcome is that we want. The ultimate outcome is for this person to leave the hospital and go back and hug his kids and go to baseball games and do the things that this person wants to do. And again, if you think about our history, we haven't been particularly successful for that. We're talking about a minority. We're talking about probably 10% of the events that we'll ever see will get us to this place. And then if you think about the next fact, which is I think really relevant, less than half of those folks of the 10% are all of a sudden going to be able to walk out of the hospital. So it's really important that we maximize our efforts. It's really important if we're going to get people home to go to those baseball games and hug their kids, we've got to do everything we can in this moment. We've got to do everything we can to make sure that we're giving them every possible chance. So, when I think about what happens here now, there's this sort of piece that we say, okay, so we got a pulse. What now? What are the things that we have to be thinking about? And I've always been a paramedic that thinks about priorities, right? I want to make this simple. I want to make things, I want to go through some very basic steps, and I think we can make it that way in this post-arrest environment. I want to think about what are the key priorities, what are the key elements that really do maximize success, that really do make it more likely that this person's going to go hug their kids. So when I think about the immediate priorities of post-arrest, I think the first thing that we have to do is, make sure that we're actually in a ROSC situation, because it can actually be pretty deceiving. For a long time, we've talked about some very traditional things that we look for to make sure that a person's in a resuscitated state. And even some things like purposeful movements are all of a sudden deceptive. We certainly know that with the advent of high quality CPR and even more so with the advent of CPR devices, like the Lucas device and, all the other devices that are out there, we're seeing more and more people with more and more case reports of purposeful movement, even though the person still is in cardiac arrest. We have people with VFib reaching up and grabbing stuff. We have notions where we're having to sedate people with cardiac arrest movement. So not necessarily an entirely reliable element. We also know that, this is not a new concept, but the traditional pulse check has not exactly been a very reliable pulse check. This is a study that looked at 206 patients. They actually were in a bypass lab, and they said, they were controlling whether the person had a pulse or not. And they brought in EMS personnel and said, does the person have a pulse? 10% of the time, the person didn't recognize an absent carotid pulse, and 45% of the time, they thought it was pulseless, but it wasn't. So, these are challenges that we have to get to. So I think when I think about determining a true ROSC state, I don't want to rely upon one thing. I want to rely upon a lot of things. And I think there's better technology that will help us out there. We talked a little bit about end-tidal CO2, and I hope you're all embracing end-tidal CO2. Lord knows it's been around long enough now. But, I think using that end-tidal CO2 is not just a valuable tool for assessing quality of compressions, which it is, by the way, but also for understanding when we see ROSC, right? We know, typically speaking, or statistically speaking, we're going to see a bump somewhere in the 10 to 13, 10 to 14 or so millimeters of mercury when that heart starts beating again. So that should be a pretty good indicator for us. The other tool that's certainly making the rounds these days is bedside ultrasound. And I think that's a really great tool, the ability to, put that probe on the person's chest and see things like this. You can see here a valve opening and closing. Well, that's not artifact. That's not anything different. That's a heart that's beating. And that's a really relevant thing, right? That's going to tell us a very different treatment strategy if we see this than a person in a cardiac standstill. And, for a lot of years, we would sort of imagine this to be a technology that only existed in the hospital. But this technology is not only getting more portable, but it's getting less and less expensive every year. And I think certainly something that we should be thinking about. For me, the relevance really comes down to this. For years, we created the notion that PEA and EMD, electromechanical dissociation, are the same thing. Turns out they're really not. And there's a hell of a lot of PEA out there that we once thought was truly a cardiac arrest condition. It's really not a cardiac arrest condition. If this person is so shocked, is so hemodynamically depressed that they just can't manufacture a pulse, that heart can still be beating. And what we know is when we start talking about how to manage that person in the environment where they're in an unconscious state, it's a very different person who has a heart that's beating from a person that's in cardiac standstill. The cardiac standstill person needs the traditional cardiac arrest management and the things that we've talked about. But the person who has a beating heart that's just, profoundly shocked, they need an entirely different profile of hemodynamic management. They need fluids, they need pressors, they need things that can support that cardiovascular flow. And it really doesn't include the CPR. So I think it's really important as we think about what the post-arrest world entails is to, first of all, make sure that we're really there. But look, that's not a talk for tonight. What I want to talk about is the person that really does have a pulse. And what we know is when we can really say this person is in a ROSC situation, a person that has been resuscitated, is we have to swing that pendulum from one theory, one philosophy, one strategic mindset to an entirely different one. When we talk about the intra-arrest mindset, that's the Mickey Eisenberg stuff. That's the pit crew CPR stuff. That's the, making sure you're not interrupting compressions. And look, I hope you're carving in stone the tenets of good cardiac arrest care. I heard all of them spoken about in the previous conversation, but this notion of running out of the house to run to the hospital, I think that's just crazy stuff. You have every bit of the therapy, every bit of the things that make a difference in terms of outcomes in that ambulance. And the notion of trying to get to the hospital so they can do exactly the same thing, I think that's just a really foolish strategy, especially when you can do it much better in the house. So I think staying put's a pretty important piece. Doing good quality compressions, getting early defibrillation, those are the things that we should be carving into stone tablets and making it sort of the core foundation of good cardiac arrest care. But when we get to that ROSC state, when somebody finally says, Dan, we've got a pulse here, there's a whole realignment that has to go on, right? We've got to change away from those tenets of cardiac arrest management into something very different. So that leads you to the proper question of, so what's so different here? Why do we need to do something so entirely different than what we've been doing before? Well, what we know is when we get to that post-arrest state, that ROSC state, what's happening to this person's body is not just one thing anymore. There's not just like a coronary lesion anymore, but a syndromic effect, a constellation of different problems that are happening all at the same time. And the reality of our care is they have to address almost all of them, right? We've got to touch on all of these things. When we think about the post-arrest syndrome, it's a complex mix of hemodynamic and neurologic and systemic inflammation, all at the same time, all occurring to make this person sicker, to make this person less likely to leave the hospital. And to properly manage this, to properly get into this, we've got to be thinking about not just immediate priorities, which are very important, but also the long-term priorities. So how do we address those elements? That's what I really want to get into here tonight. So when we think about that post-arrest syndrome, there's systemic problems, and I'll just take a second to get into this. First and foremost is our brain, right? This is a massive neurologic insult that has just occurred, not just from the anoxia, but also from the reperfusion state. What we see in this particular case is brain cells suffering from an ischemic degeneration, right? I mean, it's basically a brain injury. As we reperfuse and as they sort of recover from that anoxic issue, we see cerebral edema happening. So we see swelling of the brain, and not only that, but we have a failed autoregulation. Right, the blood flow through the brain is flawed. It's not regulated in the same way. The same chemical messengers that make it work the right way aren't working the right way anymore, and that's going to cause all sorts of primary and long-term problems, right? We know that when we talk about the post-arrest state, we see seizures, and we have a risk of seizures in that case. We see fever occurring, and we also see mean arterial pressure and transferring over to cerebral perfusion pressure problems, right? If we can't maintain blood flow through the brain, even with the heart beating, that's going to cause further problems down the road. From a cardiovascular system, we also see a number of problems there as well. We know that that heart, especially if there's a coronary lesion, which we talked about before, accounts for a great many of the cardiac arrests that we see, is a pretty unstable situation, right? So if they went into VFib one time, it's pretty likely they can go into VFib again. It's pretty likely that they can have an arrest rhythm reoccur. But there's not only that, but there's this hypokinesis, almost like a stunning that occurs to the heart that is almost very similar to like a heart failure kind of state. What we'll see is that heart muscle just not respond the same way. We'll see drop in cardiac output as a result of this stunned state. And we can see low blood pressures. We can see hypoperfusion result because of that stunning. We have to also note that we've been pumping catecholamines into these folks. In most cases, when we start talking about the administration of epinephrine, we've been putting these really massive pressors onto the system, and all of those have a half-life. All of those have a period of time in which they're going to wear off. So if this person's just full of epinephrine, 10 minutes later, that epinephrine is going to begin to wear off, and those effects are going to take its toll as well. So the hyperadrenalized state is going to become normal again, and that pressure is going to drop. So, you know, the risks associated with that in this in the post-arrest syndrome, of course, are re-arrest. So again, likely this person may go into another arrest rhythm, but also the shock state, right? The depressed the depressed cardiovascular system as a result of the stunning and the instability as well. And then finally, we also have this systemic inflammatory response, and that results from a wide variety of things. But it's actually pretty poorly understood. But this notion that the hypoxic event and the systemic ischemia is going to create this inflammatory response, and it's going to change almost every bit of the cardiovascular system. It's going to change how we regulate the dilation and constriction of blood vessels. It's going to change coagulation. It's going to suppress our adrenal system. It's going to impair oxygen delivery. It's going to have all sorts of different effects, and it has massive a massive profile of challenges that are going on in this person's body. And then finally, as we think about what's happening to this person, there's also an underlying issue here, right? So for a lot of these folks, there's some problem that's happening in their heart, like a coronary lesion. There's something that's still blocked, and as long as that remains blocked, we're going to continue to have this problem. So when we think about how to treat this person, we've got to think about the priorities that address those sorts of things. All right. So what are the priorities? What are the things that you should be thinking about? I think somebody has to mute themselves here, please. All right. So when I think about the priorities around post-arrest, one of the first things that comes to mind is the whole transport decision. And I know that you guys have some protocolized notion of staying, and I think that's not such a bad idea. You know, I think when we talk about the idea of what should we do immediately after we get Ross back, we have to balance a couple of things.
Hey, Dan, for some reason, you just got muted. We didn't do it on our end, but you might have to unshare your screen, unmute yourself, and then start it. It was just in the last 5 seconds. Why? Oh.
All right. Can you hear me now?
Go. There you go. All good.
All right. Let's see. Let's try something here then. Hang on just a second. All right. Can you still hear me?
Yep. Can hear and see your dynamite slide. Perfect.
All right. So what I was saying when we were talking about the stay or go decision, right? We've got to balance. We've got to balance the fact that this person is incredibly unstable, right? This person is just revived from cardiac arrest, and we know that about 4 out of every 10 of these folks will go back into cardiac arrest rhythm, right? They're about 40% of them will become a cardiac arrest again. And what we don't want to be doing is be halfway down the stairs when this person goes back into cardiac arrest. So there's some notion, there's some idea that, you know, perhaps we should stick around a little bit. Perhaps we should take our time and just sort of understand how this unfolds a little bit better before we go rushing off to the hospital. But at the same time, we also want to understand that a pretty high number of these folks are also going to have a coronary lesion. And we know that the longer we let that lesion stay, the more unstable they're going to become. In fact, for every 10 minutes of time to reperfusion, we increase mortality rate by about 1%. So, you know, remember when we think about the priorities, when we think about how to attack this, we have to understand.
Hey, Dan, you've been muted again. So somebody might be muting you inadvertently, because I think all participants have the ability to mute somebody. I apologize for that.
No worries. Can you hear me now?
You're good.
See, they
got
can't
you in
shut
the
me up. They're trying to shut me up, but they can't do
I
it.
think that's Joe. I think we can
I'm
blame it
gonna
on Joe.
gonna keep talking. All right. So what I was saying is, remember that when we're talking about this person, this post-arrest patient, we have to keep in mind that we've fixed a symptom in many cases, but not necessarily the problem, right? So there's a bigger picture that we have to go on. We have to remember that this person is potentially a person that's going to go back into cardiac arrest. So we don't want to strip off all the AD pads and we want to keep the defibrillators ready to go. But at the same time, we want to think about why transport is important, right? Because there has to be a balancing act here. Well, there's a little bit of research around this, and I think it's relevant to think about it. The big and most important piece is the fact that a lot of these folks are going to have a coronary lesion. Now, the question you might ask is how many of these folks are going to have coronary lesions? And I'm going to tell you, it's probably more of a question than we once thought it was. Forever, growing up through it, I've been in EMS for 30 years, and we've talked about the idea that what percentage of cardiac arrests occur because of a heart attack, what percentage of cardiac arrests occur because of lesions, and we always assumed that it was a high number. Is it 89%? I've heard 80%. But the reality is we just don't have great data on that. And one of the challenges that we have to think about as we think about the idea that cardiac arrest care hasn't evolved a whole lot in the last 40 years is we need better information on this. But nonetheless, there's at least some research out there to suggest that it's a pretty high number, right? This is a study that they did over in France. They looked at 435 presumed cardiac arrests. 70% of them had a lesion. If the person had ST elevation on the first EKG after the cardiac arrest, that number was 96%. So we have some pretty predictive states. The other thing that we know in that same study was that when we found the person with a lesion, right, and we got them to the cath lab, it was an independent predictor of survival. So we know that if we could get them to the cath lab, we could open up that lesion, more people lived. So that's why I think there has to be a balancing act. That's why I think it has to be this idea of, okay, we want to stay and we want to be prepared for the next dysrhythmia to occur. But we also want to keep in mind that there's a fairly substantial number of these folks out there who are having a myocardial infarction, who are having a blocked coronary artery. If we hang around too long, we may actually be counterproductive in that regard as well. All right, so what are the things that are really important when we think about what has to happen in the post-arrest state? We got to do a 12-lead EKG, and it doesn't matter how many 12-lead EKGs you did prior to this event. We need one in the post-arrest state right away. What are we looking for? We're looking for a STEMI, right? Now, certainly there are lesions that occur without a STEMI, right? We know that somewhere in the order about 70% of myocardial infarctions will occur without an ST elevation presentation, at least initially. So there's a whole lot of people out there. But the fact of the matter is if we can identify it, we then know what we have. We then know what to do. And we then can shift some protocols to be pushing towards that. Now, I don't want to get too deep into this. There's lots of American College of Cardiology has some guidelines around this. I'm happy to share with you if you want to. But the notion is that there's recommendations. There's hard evidence to say if we're finding ST elevation in the post-arrest state, get this person to a cath lab, get them into a place where we can do something about that kind of piece. Probably the simpler way to think about it is there's also a category of patient who probably doesn't fit this. And these are the folks who've been down for a long time. These are the folks who have a non-VFib cardiac arrest or no CPR, that kind of stuff. There's folks that the cardiologists are going to go, they aren't going to the cath lab. But I think it's worth our time to kind of understand that a little bit. If you want to break it down even simpler, I think it goes like this. The people who are likely to get a cath lab after a post-arrest state are the ones who have a STEMI, who are the ones who've had a VFib or a VTAC or shockable rhythm arrest. Typically the sudden etiologies, that is not the submersion injuries, not the not the traumatic injuries, that kind of stuff, and maybe some of the cardiac markers. On the other hand, the people who are less likely to go to that cath lab are the ones who don't have a STEMI, who are the ones that present with an asystole or PEA arrest, and the ones who have an asphyxial cardiac arrest origin. Again, it's not 100% clear, but I do think that getting that 12-lead EKG on early really helps make this decision a little bit more simple. Now, the other thing that we've got to be thinking about in those early priorities is where we're taking this person, right? And I know that not all, look, I'm from Vermont, And there's a whole lot of situations in Vermont where, the nearest hospital is the best choice. And I want you to follow your local guidelines for this. But we do want to be thinking about this post-arrest patient like they're having a heart attack. And, Grace Cottage Hospital is a wonderful hospital, wonderful local critical access hospital. But I don't want to bring a post-arrest patient to a small hospital that doesn't have PCI. Given the notion, particularly if they have an ST elevation on the EKG that I just did, but even if they don't, this person needs somewhere where they can have more of a high-level cardiac intervention. They need the bigger, larger cardiac tertiary care center if it's possible. So again, follow your local guidelines, but be thinking about destination choice as well. All right. Other parties that we have to think about are oxygenation. And I know certainly we've talked about that a little bit in the last talk. When we think about the intra-arrest airway priorities, the intra-arrest oxygenation priorities, this is a pretty low priority. And I know we were talking earlier about CCR, and I think it's a great notion. I think that the idea of really focusing on circulation and CPR fraction and not worrying so much about airway in those states, especially in the sudden cardiac origin, cardiac arrest, I think that makes great sense. So I think that's a different standpoint, though. But when we start talking about, the role of oxygen in cardiac arrest state is a pretty interesting one. I think there's more and more growing evidence that we shouldn't be forgetting about it. That the idea of just get in there and don't worry about airway. Okay, but if we're giving ventilations, I think we should be thinking about oxygen. There's a growing amount of not great evidence, but a little bit of evidence out there that suggests if you're giving ventilations, you probably should hook it up to the oxygen tank. Okay, intra-arrest, what's the right airway management role? Look, I think there's a ton of different studies out there that can point you in a bunch of different directions here. In a cardiac arrest state, I happen to be of the ilk that says, I'm going to use whatever airway management technique offers me the easiest and simplest way to get air in and out of my person. I think there's a little bit of evidence to suggest intubation makes a difference. There's a little bit of evidence to suggest that it doesn't. I'm not convinced. And again, if you want to talk about the pro stuff, there's research on this side. There's also research on the other side. I'm not convinced one way or the other in the intra-arrest state. However, in the post-arrest state, I think that priority has to shift quite a bit. Where we're not worrying so much about airway and oxygenation in the cardiac arrest state, I think in the post-arrest state, we have to worry about it a lot. I think our priorities here have to be to prevent hypoxia, to prevent hyperoxia. We'll talk about that in a second. We need to prevent hyperventilation, and we need to guard and protect that airway. So, there's some different stuff that we got to think. We got to shift that pendulum over again. I think the most important thing that I can say in terms of airway and oxygenation in the post-arrest state is simply this: hypoxia is bad. We know we certainly can point to this as a causation for poor outcomes. We know that when people are hypoxic in the post-arrest state, they die more. So if there's one thing that we're going to think about in terms of oxygenation and airway is simply prevent hypoxia. I think that's the most important thing that we can talk about. Now, at the same time, we also want to balance a little bit, because that doesn't mean we want to put 4 non-rebreathers on the guy and pump oxygen in through his ears, right? I think there's got to be a balancing act that we play here where we say, yes, we need to maintain saturations, but we also don't want to go crazy. Now, this is not entirely, I happen to believe it's true, but it's not entirely supported with a whole bunch of great evidence, right? We believe that it's true. There's one very good animal study where we can point to it and say, look, when we made this animal hyperoxic, they died more. And there's a couple of human trials where this is not quite perfect evidence out there, but I believe it's true. And I think that when we think about what to do in the post-arrest state is, number one, do not let their saturations dip low, right? And I know the AHA is kind of waffles around a little bit. I think we should be really targeting somewhere between 94 and 98. And again, I'll ask you to follow your protocol. But I think one of the pieces that there's 2 studies now that really demonstrated that it's difficult in the pre-hospital world, and I'll show them to you in a minute here. Actually, these are the 2 right here. There are 2 studies that actually demonstrated that titrating oxygenation to saturations of the pre-hospital world is a difficult thing. Not impossible, but a difficult thing. And I think because the risk of hypoxia is much higher than the risk of hyperoxia, at least in the research that's present so far. I think I'd rather err on too much rather than not enough. That said, don't go crazy. And I think we can use the technology that we have. We can use pulse oximetry. We can use just good patient assessment to make sure that we're staying in that range. So I'm going to say I think it needs to be somewhere between 94 and 98. And again, that's not different than what the American Heart Association says either. Know that there are folks out there who say differently. Know that there's quite a number of people. These are down in Australia, the CHEER trial, when their preliminary data came back, showed that it probably actually ought to be a little bit higher, that we ought to be erring a little bit on the higher side of that frame. Who's right? I don't know. There's not enough evidence to support one way or the other, but I think we should just be mindful that we definitely don't want to dip it low. The bigger question comes down to airway and what should we do about it? Now, look, again, I think in the post-arrest state, unlike the arrest state, I think we do have to be more concerned about airway, right? With a person that has changing levels of consciousness, we do run the risk of aspiration. We do run the risk of maintaining an airway. I don't think we have to intubate. I think if you're using a BVM and an OPA and you're using good two-handed thenar eminence technique and you're ventilating well, I think keep doing that. And I'm happy enough that you do. I also, though, think that in this particular case, intubation is not a bad idea either. The real risk around intubation is probably not the procedure itself. It's more about the hypoxia that occurs because of the procedure. And when we think about what happens in this particular case, what we see is that it's just not a procedure that we're doing a lot. And look, I'm a big intubation fan. As a paramedic, I grew up intubating people. I think it is something that we can do well. But the problem of modern intubation is that we don't have the OR opportunities we once had with cardiac arrest care the way it is now and the rise of supraglottic airways. We're simply not getting the practice. And what we know is every time we're trying to intubate and failing, and every time that attempt occurs without success, we run the risk of creating more hypoxia. So I think if you're really good at intubation, I don't think there's any reason to worry about it. I think you should. I think if you have the capabilities to practice it regularly and have a good training program for it, I think a case can be made for intubation. But at the same time, what I want you to be very careful about it, and as a team approach it, we should not be allowing folks to be attempting multiple intubations and watching this person become hypoxic, because every incident of hypoxia in this post-arrest state is increasing mortality. All right. We also mentioned the notion of that balance between hypoxia and hyperoxia. Well, the same analogy can be brought forward to the notion of hypoventilation, that is not ventilating them enough, but also preventing hyperventilation. Look, these cardiac arrest states are pretty high stress situations, and I know there's a lot of you guys out there going, I've been doing this for 50 years, Dan. They don't stress me out, right? But for every one of you, there's still a lot of new people out there who do get a little bit of a heartbeat, who do get a little bit of an adrenaline rush when these situations happen. And what we know is we have a tendency in these moments to ventilate a little too fast. And there's a reasonable amount of evidence out there that would suggest that as we hyperventilate people, we have a lot of problems that occur. One is we can auto-PEEP people. That is, we're not allowing people to fully empty their lungs and we're kind of just recirculating the air that's in there. The second thing is, if we start getting into hyperventilation and increasing volumes, there's barotrauma and also preload related issues. The more air we put into the chest, the less blood that can return back to the heart. So we can actually be dropping blood pressure as a result of it. And then also the getting rid of too much carbon dioxide is also a negative problem there as well. So I think it's important for us to be thinking about that and not only helping one another and coaching one another and using some of that same incident command model of PIT crew CPR to have somebody watching over ventilation and giving feedback to say, hey man, slow it down just a little bit. We're okay here, and focusing on the rates as we talked about before, but also using technology. Certainly when we talk about end tidal CO2, we've got the tools here to help us do the right thing. And when we keep that end tidal CO2 between 35 and 45, that's when we know we're ventilating them at the proper state. So I think that makes a good bit of sense. I was also happy to hear in the past talk about the idea of being careful about using volume, right? When we're using too much volume in this BVM and too much force of volume, we can potentially do harm in that parenchymal tissue, in that lung tissue. So, when we're thinking about that BVM, we're thinking about slow and gentle ventilations with just enough volume to raise the chest. We don't need to be blasting their lungs away. And again, think about how that stress, especially in the folks who aren't used to these situations, is affecting our technique. I think there's a case to be made that we should be thinking about ventilators. Now, I'm not a huge fan of the automatic transport ventilators, that were around for many years. But I think if we're talking about transporting people that need to be mechanically ventilated, there are much better tools than the human species to do this, right? There's much better devices, and I think the sooner we can take the human factor out of ventilation and put it to a very controllable rate and a very controllable tidal volume, I think that makes sense. And there's a certain degree of evidence that supports that as well. Okay, but there's a lot more to talk about with post-arrest care. There's a lot more to talk about that post-arrest syndrome, right? The other big piece that we have to be thinking about is hemodynamics, right? And we know that keeping that brain perfused and keeping that neurologic state protected depends upon good systemic hemodynamics. So the other big priority that we have, and the other big really important fact that we have to be looking at, is preventing hypoperfusion. We've got to stop them from having low blood pressure. We've got to stop them from being in a shock state in this particular case. Now, I think it's important to understand the artificial state that most of these folks are in the ROSC when ROSC occurs, right? And the artificial state occurs because we've been pushing pressors into them for 5, 10, 15, 20 minutes, and now we're assessing their hemodynamic capabilities. Well, that's okay, but if you've just pumped full of a kit full of epinephrine into this person, that blood pressure is entirely artificial. Now, when I was a young paramedic, we used to say, okay, we got the pulse back good. Just leave them alone, right? Don't worry about the blood pressure for a little while because it's going to auto-correct itself. What we now know is, boy, that's a really bad strategy. That's entirely incorrect, right? These folks are hanging over the precipice. They're hanging over the vast chasm, and if they fall into it, they're going to die. And what we now know is that hypotension kills, and that any episode of hypotension, any episode of hyperperfusion in the post-arrest state results in increased mortality rate. There's no circumstance where we should be allowing a low blood pressure in this moment, no matter how soon, no matter how long ago that resuscitation occurred. We need to correct it immediately. And the reason why we need to correct it immediately is because blood flow to the brain depends upon that mean arterial pressure, right? We've got to maintain systemic hemodynamics if we want the blood flow to go to the brain. And remember that in this post-arrest syndrome that's occurring, that brain is no longer auto-regulating its blood vessels the way it did before. It can't maintain the cerebral perfusion pressure in the same mechanisms that it did before. It's depending upon MAP to stay perfused. If it doesn't have MAP, that brain is going to die. So, moral of the story, there's no such thing as an okay low blood pressure. There's no time at all where we should say a blood pressure is low and that's okay. Now, you might then say, Dan, well, what does that mean? What's a normal blood pressure? American Heart Association, in all its wisdom, has said it continues to hang on to the systolic blood pressure. Okay, if you want to grab a systolic blood pressure number, it's probably 90 as the lower threshold that we have to. But this is a really bad way to measure anybody's perfusion. It's a really bad way to look at the overall process, right? In fact, there's some people who say it should be higher, but again, we won't get into that too deep tonight. The reason I think blood pressure is a really bad measurement is because it's so different in different people. The notion that a 300-pound biker and who's been doing crystal meth all day, is going to have the same lower threshold of systolic blood pressure as the 90-pound little French lady who's soaking wet with rocks in her pockets, weighs 85 pounds, is ridiculous, right? So I think there's a better way to think about it. And I think the better way that we think about it is to think about mean arterial pressure. Now, I know you weren't brought here to do math, and no one wants to be calculating MAP in the back of an ambulance. And maybe you're going to bring a chart in there and measure it out. But look, if you have a monitor that was bought after 1976, all you got to do is look in the little corner and it's going to give you the MAP right there. This is a pretty easy number, and it's a pretty available number to us if we just kind of get to the place where we're choosing to use it and we're choosing to get to that measurement. So I think that's where we ought to be targeting, and I think we ought to be targeting a MAP of 65. By the way, so does the American Heart Association, and so do a number of other experts out there who say, look, that's where we should be, and that's going to give the ability to adjust blood pressure in the little tiny lady that's hypotensive on a good day, and the super hypertensive guy that's always hypertensive. MAP is going to find that middle ground, and I think that's the target that we really ought to be working on in this post-arrest environment. Again, understand that there are folks out there who say MAP should be a little higher, right? The American Heart Association chose the lower number. There is a number of experts out there who say MAP really ought to be more like 80. Some out there who say it ought to be more like 100. I think 100 is too high, but I'm not saying that 80 is wrong. I think it may need to be a little higher than that, but I think we need a little bit more research to decide for sure. Okay. Now, the other thing that we have to keep in mind is that when we maintain blood pressure, when we make sure that we're keeping the hemodynamics stable, what we're also doing is preventing a lot of the inflammatory cascade that's going to cause some of the systemic syndromic problems later on. So not only is it an immediate priority, it's a long-term priority as well. So what are the action steps that we can take as a result of that? Well, first of all, we got to optimize preload. We got to make sure that this person has enough blood in that heart so that when it squeezes, it gives you the cardiac output that you need. The second thing that we have to do is optimize afterload. Remember that systemic inflammatory response is in many cases affecting afterload. It's causing vasodilation when vasodilation shouldn't be there. It's causing some of the low blood pressures as a result. And then finally, we need to optimize contractility as well. Now, in the intra-arrest state, again, we have some different priorities, right? Now, I don't want to pretend that CPR and fluid are necessarily antithemal. I think there's a case to be made for giving somebody fluid, especially if there's a risk for hypovolemia. Although I don't think that we should be just going in there and nominally giving them 2 liters of fluid. I know that for many of you, especially who've been around for a long time, that was pretty much the action steps that we took. We gave a bag of fluid when we were doing cardiac arrest care. I think the evidence really doesn't support that, and I think that again, if you have a hypotensive situation, a hypovolemic situation, a reason to suspect hypovolemia, there's nothing wrong with fluid. But at the same time, I think the arbitrary administration of a big bunch of fluid is problematic. It's problematic on a couple phases. One is that if the person's not hypovolemic, you're going to make them hypervolemic, and that's going to be a problem they're going to have to deal with. Second, remember that the fluid that we're giving in most cases is cold, and although there's a case to be made for hypothermia therapeutically, generally speaking, that's not so great in a lot of people. And then third, most of these fluids are pretty acidotic. So as we put them in there, we're actually affecting pH. So I'm not a big fan. I think, again, if we have a case to be made for a reason to give it, fair, but I'm not one in a cardiac arrest state to just be giving a bunch of fluid just for the sake of giving it. However, when we get to that post-arrest state, I think there is a case to be made a little bit different. Now, if you ask me what the evidence says, Dan, about giving fluid in the post-arrest state, I'm going to tell you that it's a really empty bucket. We don't have a lot of great deal of evidence to say this is how much you should give, this is how much you should withhold. There's some studies out there that can point to some directions about how much and when we should give it out there. This is the big one. This is a study that was looking at hypothermia, therapeutic hypothermia, and one of the ones that pointed us away from it in the pre-hospital environment, right? We said, be careful about it. But it really wasn't so much about the hypothermia that caused the problem. It was the fact that we were giving a ton of fluid to get to the hypothermic state. This is the when we first adopted therapeutic hypothermia protocols, we were pushing like 2 liters of fluid into people to get them to the targeted temperature states. Well, it turns out that when you push 2 liters of fluid into a post-arrest heart, we tend to see things like pulmonary edema occur. And that's not such a great thing if you're in a post-arrest state, right? Making a person hypervolemic with a heart that's already unstable and stunned, that's probably not where we want to be. On the other hand, I think it is important to maintain preload. And I do think in a post-arrest state, in a person that's hypotensive or has a mean arterial pressure that's below where our threshold would be, I think it's important to maximize preload. So I think we do give a little bit of fluid. I think the best lesson, I heard this, an instructor state this in a class a little while ago. He said that fluid really needs to be in parallel in this post-arrest state, right? That we want to be giving fluid, but we also want to be thinking about pressors. And one, it's not a linear step, right? It's not you do fluid first and then pressors. It really ought to be both, right? We should be taking that 1-2 punch against the hypotensive state in the post-arrest situation. So here's how it works in my brain. And again, although there's not a huge amount of evidence to support it, I think you give the fluids as you get everything else ready. So we start running the fluid, as we're preparing the pump or as we're preparing our push dose pressors. That's going to allow a little bit of preload response, which is not a bad thing. And we know that most people in a post-arrest state can benefit from a certain degree of fluid to increase preload. I think if you're giving more than a bag, 1 liter of fluid in a post-arrest state before you give a pressor, you're probably wrong. Although I can't tell you that I have a great deal of evidence to support that. I think, but that's the starting point. And then I think as we give the pressors, we continue the fluid, and that's where that sort of the second liter comes in. And again, it's a little bit situationally dependent. Obviously, I don't want to do that in a person that's got a long history of congestive heart failure or has, wet lung sounds or things like that. But I think that the notion is it's a parallel process, right? I'm giving a little bit of fluid to help preload. I'm going to give the pressors immediately without delay, without waiting for the effects of fluid resuscitation to maintain that blood pressure. All right. So as I'm optimizing preload with fluid, I'm also going to optimize afterload. And you might say, Dan, what's the right pressor? Again, the evidence is not clear on this at all. I think probably the one that's most accepted is norepinephrine, Levophed. I think it's pretty reasonable, and I think it's pretty effective. It's going to give you a little bit of the alpha. It's going to give you a lot of the alpha, a little bit of the beta. And again, the hard part with Levophed that I don't like, though, is it's hard to figure it out, right? There's a lot of mathematics involved in it, and it's a complicated process, and again, I don't want to get too deep into this because we're short on time tonight, but unless you're getting it in standard packaging, there's a lot of mixing and there's a lot of, different concentrations, and you've got to be very careful. We also have to be very careful that we don't want to piggyback it, right? It needs to be the actual infusion itself. And then also remember that when you start talking about some of these pressors, particularly Levophed, you've got to be very careful that you're not that it's not infiltrating, because it can cause some pretty significant damage to the soft tissue as a result. And finally, I don't know anybody that's using a pump enough, at least in my world, especially in rural Vermont. There's nobody that's using a pump enough to feel comfortable with it. So now all of a sudden we're in this hyper stress situation with a post-arrest patient, and we're trying to figure out how to do the math around the infusion. And then we're also trying to figure out how to use the pump that we haven't used in the last 6 months. I think that's a really complicated state, and I don't love it. Okay, you might say, well, maybe we should use dopamine, Dan. I think there's a little bit of evidence to suggest that dopamine is a little more pro-rhythmic, and that is it can potentially cause more cardiac dysrhythmias, and that's why we've sort of moved away from it. But again, there's some experts out there who say they really like it. And, what we're doing with this dopamine is giving a number of different effects depending upon the dose. You might get beta and the intermediate effects, or alpha and the high effects. So there's some people out there who really like it. Again, the other problem that we get into is we're still calculating drip rates and using pumps and stuff like that. I think those are really difficult challenges in a pre-hospital environment. certainly not ones that I want to get into, right? And far too often with either one of these pressors, and particularly dopamine, and I've heard this stated by paramedics far too many times than I'd ever like to admit, we can't just titrate to effect. We can't just be running them open. We're going to kill people with that process. So we've got to be more specific. I was really happy when we started talking about this class to learn that you're thinking about push dose pressors. I wanted to point out this study. This is a pediatric arrest research where they're looking at the post-arrest kids. And what they determined was that systolic blood pressure less than the 5th percentile within 6 hours of cardiac arrest was associated with mortality. So they pointed to the idea that post-arrest hypoperfusion kills kids, but only 41% of hypotensive kids received inotropes. So that means that there was a whole bunch of kids, and this is a hospital study, by the way, only half of the kids that needed to get pressors got pressors. I think that has to do with the fact that it's complicated, it's hard, it has to do with math. I think there's all these things that sort of push it away from us, and there's far too many circumstances where we go, well, let's just go to the hospital, we'll get it done there. Well, that can't be our mentality in a post-arrest patient. We've got to be giving these folks the pressors that they need right away. So I was really happy that you're talking about push dose pressors, because I think that makes great sense. Why I love push dose pressors so much is that they're simple. We in Vermont, thank you, you Pennsylvania people out there. You gave us our first push dose pressor. Now, I know it seems complicated here, but it's really not. I mean, we use 1 to 10,000, 1 to 10 epinephrine all the time. And people are familiar with it. They're comfortable with it. They're comfortable with the bolus dosing. They're comfortable with drawing up those medications. I think this is something that's really lends itself to a high stress environment, especially as a bridge, right? Because what we find in Vermont is in some of the cities in Vermont, push dose pressors are all you need. You're 5 minutes away from the hospital. We want you to give the pressor, but you don't have time to get the pump out. Good, give them the push dose pressor. In other places that have a longer transport time, we do need to give we do need to get the pump out and maybe monitor these medications a little bit more carefully. But what a push dose pressor does is give you time to take a breath. It gives you time to calm down a little bit, let your partner start working on the pump over there and pulling out the little manual. You've got to do whatever you need to do, and then allowing those folks to sort of have a calm head and look at this. You've stabilized the situation by giving the push dose pressor, and now we can move to the next step if we have to, but we have more time and a more calm brain around it. Now, this is your dose. I want you to follow your protocols on this, but I think this is great stuff, and I think we should really be thinking about it. All right. There's a lot of conversation around therapeutic hyperthermia. I don't want to get too deep into this tonight, but know that there was a couple of research studies, and those research studies are still valid, by the way, that say that a therapeutic state is neuroprotective, that if a person remains unconscious, to cool them down to a targeted temperature is actually going to increase outcomes, going to improve neurologic outcomes going on there. Nobody disputes that, by the way. It lost its approach in pre-hospital medicine when this study came out. And what it basically said was there was very little difference in neurologic outcomes between a targeted temperature of 33 degrees Celsius and 36 degrees Celsius. And it was also followed by this study that, as I mentioned before, demonstrated that they had some pulmonary edema and stuff associated with it. Now, everybody, this is a classic example of emergency medicine jumping to conclusions without actually reading any of the studies and everybody jumping on the bandwagon. Everybody took these last two studies to say that pre-hospital cooling is bad, that you shouldn't do it, that it's somehow harmful. But none of those studies said that. It didn't say that they were harmful at all. It just said that they weren't any better. And what it did tell you, what it did show us, is that in most pre-hospital circumstances, the person's temperature was dropping anyway. And that they're in this hypometabolic state, right? They're not really doing a lot of metabolism because their muscles are sort of in this dead state. That they're not generating heat, and we're also pumping cold fluids into them and stripping all their clothes away. So that most people who are coming into the hospital are in that targeted hypothermic state anyway. So we probably don't have to worry about it. And secondly, we probably shouldn't be coming in there with 2 liters of cold fluid and making them hypervolemic. So I happen to be in that camp. I think if you want to make a case that giving people cold fluid and too much fluid is the wrong choice, and if you want to make the case that, look, they're going to be cold when they get there anyway, and it doesn't really matter to make them colder, I'm 100% there. But I don't believe, and you should take the time to read those studies so you can refute the physicians out there who say, oh, it's harmful, it doesn't make any sense. I think that's not the right way to go. There's a really interesting study that was done not long ago, and the results aren't fully reported yet, but it actually looked at stopping using intravenous fluids, and they used cold air blown through a kind of like a nasopharyngeal airway, and to see what would happen if we cooled people that way instead of using the cold fluids. Not a lot of good information out of it yet, but that's going to be kind of an interesting piece to think about. All right. Last thing, and I know I'm a little over, and I want to make sure you get out of here on time. The big question that we get all the time is, what about antidysrhythmics? Should we give amiodarone? Should we give lidocaine? Should we give it to a person to prevent dysrhythmias coming back? Lest anyone think that there's research here, there's not. It's a complete empty bucket when it comes to that. In fact, there's about as much information on giving antidysrhythmics to a post-arrest patient as there is for any of the Three Stooges poke in the eye therapies that occur out there. In fact, there's never been a study that has demonstrated a clear survival benefit for any of amiodarone or lidocaine or any other antidysrhythmic in the post-arrest cardiac arrest state. In fact, there's been the ALPS study that many of you saw go on a while ago, really demonstrated that the survival benefit between amiodarone, lidocaine, and placebo, that is saline, was almost exactly the same. So I'm not going to go ahead and say that you shouldn't give antidysrhythmics. I think sometimes a lack of evidence is confused as evidence against. We just don't have any evidence to suggest that it works. I think if you're talking about a person that is in and out of ventricular dysrhythmia, I think you might have a case to make to give a little bit of either amiodarone or lidocaine in a notion of preventing it. But what we don't want to do, and what I think is pretty conclusive, is we don't want to give it just for the sake of giving it. And that we don't want to develop protocols that say everybody gets amiodarone in a post-arrest state or everybody gets lidocaine in a post-arrest state, because it's just not, the evidence for that is just not there. All right. I want to wrap up. Let me just skip ahead here. I hope you've seen some themes tonight, and I hope I've offered you some help on this. But I think the key things when we start thinking about the post-arrest state is to recognize the state, but also to reorient your circumstances, right? To make sure that you're shifting from those intra-arrest priorities to the post-arrest priorities. I think it's important that we think about the problems, but not just treating symptoms, right? We got to think about that full spectrum of events that is occurring there. We definitely want to correct hypoxia. We definitely want to correct hypoperfusion, and neither of those can wait. We've got to stop what we're doing and do there and be very aggressive with that. And then we also want to beware of rearrest. I'll end with this, and I'm a big checklist fan. I love checklists. This is from the Heart Rescue Project, Mickey Eisenberg's team. This is their emergency department post-arrest checklist. I think we could probably cut this in half. Obviously we're not going to worry too much about some of the later pieces on there, but I think going through this and kind of making our checklist as we think about the same way we do PICC CPR, the same way we do some of the other therapies, and just having a person that's out there saying, hey, let's make sure all of these priorities are done, makes a lot of good sense to me. All right. This is my email address. This is my Twitter handle. I hope this has been helpful for you tonight. Thank you very much for including me in your talk, and I'll be happy to take questions if you have them.
While we're waiting for any questions to come up, and please feel free to speak up, I can't help but point out that throughout this is our 5th session of this, and almost every speaker has hit on something that Trumbull is doing in their protocol. One of the newer things that we're doing in our protocol, and Mr. Batsie, just the same as others. And I believe that's showing us that evidence-based EMS is where it's at. These aren't anybody's opinions. These aren't anybody's anything. We don't collaborate. We didn't collaborate with Mr. Batsie. But if you notice, a lot of the changes we've made in our protocol, and that are especially coming out in the next version of our protocol, have been backed up by a lot of the experts we've brought to you, and that makes me really happy, to be honest with you. That gives us I don't know, that gives us a little feather in our cap. So I think it's really important also that I recognize Larry for a lot of the changes in our protocol, and Ken Jones for helping out with this protocol committee, because it's been a grind, and I know it's been a while coming out. It's been a grind, but it's just us doing it. But I love the fact that we're being backed up by folks that we don't even know, that are obviously leaders in EMS from all over the state and country.
Yeah, Matt, and I'll second that. It makes me really happy too, right? Because I think that's the whole notion of the FOMED movement, right? The free open access medical education. These are the ideas we should be sharing with one another. You know, cardiac arrest isn't different in Ohio than it is in Vermont. And if you've got good ideas, we should be picking up those good ideas and using them here. And especially when we begin to do the research that supports them, and to make good ideas based upon evidence, I think that's exactly how it should work. So kudos to you guys for what I think is a really great protocol, by the way. And I did take the time to go through it and take a look at it. And I think we're going to take some stuff here in Vermont to take a hard look at some of the things you guys are doing in some of your other areas. I think it's great stuff.
I would love to see that happen across other states. We also have some interest in some of the things we've done with our acute coronary syndrome and congestive heart failure protocols that are being looked at by the state of Massachusetts.
Good stuff. Well, I'll stop sharing here, but I'll just say if anybody has any need for this stuff, if you want to share, look, please read the research that I'm putting out to you. And if I'm wrong, tell me I'm wrong. I think there's also it's also really important for us to have these discussions, and to be, you know, as a profession, you know, one of my pet peeves is that we're one of the only professions that gets to be taught and regulated by people who don't do our jobs, right? And I think it's far overdue that we take the opportunity to read the research and understand the research and be able to be conversant in the research. So, you know, please, I hope my ideas have been backed up pretty well by some research here. Read it and tell me I'm wrong and correct me, and let's debate it. And, you know, that's how this is supposed to work. And I think the more we can do that as a profession, the farther we're going to get.
Awesome job, Dan, as usual. Very, very well received by this group. So thank you so much for doing it too. Really appreciate it.
Anytime, Joe, anything, you know it.
Well, I'm kind of surprised there aren't any questions on this one. You must have done a really good job explaining everything tonight.
Or maybe it's 9:17 and all those natty lights that we're drinking out there.
If there aren't any questions out there or anything,
all those bush lights.
Everybody can feel free to hang around and BS if you like. I'm all for it. But you know, anybody who's, you know, done and ready to go, I've already taken the attendance and everything. Feel free. Thanks for coming tonight, guys.